need to carefully ask questions. So that's all from my side, sir. Please take over.
Vimal Kannan, your question.
Sir, see, might be this dull aching pain, giving more focus into this dull aching pain and arriving at a diagnosis for a retrobutal mass. So this, most of these patients, they may not be able to find out what is a pain and whether they have got all these GA symptoms, all these blah, blah. So they may have, they might have got some discomfort that they might be expressing as a dull aching pain. I just want to clarify the presenter whether she is presenting in that way, whether it is discomfort on that side or it is a clear-cut pain which the patient is feeling there. The presenter, I'm just wanted to put your question now, whether it is a form of discomfort the patient is feeling or it is a pain as such.
So, when she told, she was telling she was having some dull aching pain. It was not very severe in intensity.
Okay. At what time the patient feels the pain? Is there anything with duration with food intake or with early morning or something like after stools or something like that?
No specific association with any of these practices.
Is she able to localize the pain to which area it is? Whether it is lower abdomen or the right side of abdomen?
She is able to localize to the right lower abdomen.
Okay. Okay. So common right lower abdominal pain in a female is more likely to related to gynec pathology. This is a common thing. So only then comes your bowel and comes your all these things. More of a bowel pain or colicky bowel pain or something like colitis will have a diffuse pain or on the left side or near the umbilicus or something like that. So common any lower abdominal pain in a female is urinary or gynec. You have ruled out all these urinary and gynec problems in history?
Yes, sir.
You have ruled out, right? So nothing related with urination or something like that, right? This pain is not related to urinary features or something like gynec issues. She doesn't have any postmenopausal bleeding.
No, sir.
All these things, fine. And Sir was explaining about ureteric stricture and something like that. You were able to find out that, or it could be a ureteric colic also. So sometimes, usually it will be a colicky pain and intermittent, as Sir was explaining, and dull aching pain will not be of a characteristic of a colicky pain. Fine, ureteric calculus. So common lower abdominal pain is commonly in a female is related to gynec. Then next comes your this urinary. Fine. So locating a right lower abdominal lower abdominal pain in the RIF region, then you have to rule out all these things. Right? These are all the common things or common always. Since it is just like the Sir was explaining, since it is an RIF mass, you should not always think it as an cecum and all these things. It could be an ovarian mass also. Ovarian mass, because of space, it might enter into the abdomen. It might be an ovarian pelvic abdominal mass also. Fine. In ovarian pelvic abdominal mass, there need not be any, not all ovarian masses will produce bleeding, not all ovarian masses will produce gynec symptoms. Right. So almost 80% of epithelial ovarian cancers will present only in the stage 3. So this could be an ovarian mass when pertaining to history. Right. Because in history, what is the single feature you got? It is a dull aching pain on the right side of lower abdomen, right?
Yes.
This is the only significant point you have got. And she doesn't have any other symptoms related to any other system, right? That is fine. Not related to musculoskeletal or GI or urinary or genital, anything. Right?
Yes.
So even then it could be an asymptomatic ovarian mass. It is much more common in a postmenopausal female where epithelial ovarian cancers are more common. And they are also present in the advanced stage. So, and this patient might have a vague abdominal pain, predominantly on the side where the patient has got. Right? Since you are in surgical side, you should not skip the ovarian pathology or uterine pathology in a female patient. Right?
Yes.
You should know at least a little bit of that. You should have at least basic insight into that. Common. Just think about a common lower abdominal pathology in a female around 50 years. It is ovarian mass or an uterine mass, right? And only then comes your colon, all this, because there is no GI symptoms, no urinary symptoms, nothing else is there. Fine.
Can we go to the next slide, sir?
Yes, sir.
Sarjan, sir. Vimal?
Yes, sir. Yes, sir. Please, sir. Please, sir.
Yes, sir.
Rajgopal, sir. Can we go to?
Yeah.
Good, go, ma. Please keep going, ma.
Yes.
You just project the slide. Wait if they want to ask any question, or you can go to the next slide.
So, okay, Dr. Guru Shankari, please, you said there is no significant family history in your patient.
Yes.
So what was there in your mind that you will consider as a significant family history?
Sir, I would like to ask whether a patient had similar complaints in any of the family members. Another thing I would like to ask is any of them have any history of tuberculosis, and I would also ask rule out malignancies among the family members.
Okay, what malignancies in particular you have in mind?
Sir, any colonic malignancy, any ovarian pathology or endometrial, or any carcinoma breast.
Okay, as far as the history of similar complaint is concerned, it is unlikely that you will not, any family member can never have a discomfort, lower abdominal discomfort, that at any time, irrespective of the cause, any of the family member must be having this lower abdominal discomfort. Other thing, okay, from the history, we cannot make out, like sir said, any female patient with non-specific abdominal symptom that cannot be attributed to any intra-abdominal organ. A pelvic primary, the ovarian pathology might be, it should be considered as the first, and followed by, okay, by exclusion, a retroperitoneal pathology or lymph nodal or the other connective tissue structure should always be kept in mind if you have a malignancy or other things. And can you tell me, like you said about the history of surgery, are you aware of swelling that can occur in reference to previous history of surgery that are related to the surgeries, swelling that may occur in lower abdomen?
So any abdominal surgeries can produce incisional hernias.
Yes, very good. One is incisional hernia. Any other swelling that you may get? Is it desmoid tumor? Are you aware of desmoid tumor?
Yes, sir.
Okay, thank you. That is all from me, sir. From my side.
And you said something about ovarian cyst 20 years back.
Yes.
Hello, presenter. She's online. Yes. So
Yes,
by
sir.
that time, she would have been under the age of 30 years. So
Yes.
what an ovarian cyst you suspect by 30 years?
Sir, it could
She will be in the
benign-
reproductive age. Fine. Yeah, she will be in the reproductive age, and she has been, just think about that. She was in the reproductive age. She'll be around 30s. She has undergone some surgery and she is asymptomatic till now. Do you think that could be a malignant ovarian tumor or a benign tumor?
It's very unlikely, sir, because asymptomatic
unlikely,
for more than 20
asymptomatic
years
for a long time, and this goes, and the patient is not been under any follow-up, so it's more likely to be a functional cyst or something, anything else. Okay. Do you have anything related to endometriosis or something? Because she is having dull aching pain and she has got underwent treatment for ovarian cyst 20 years back. Okay, so that is more into a gynec, so unrelated to your surgical side.
Yeah,
so
just
nothing. You can just pass on to the same. Fine.
Yeah, just
Thank you,
want to add that one more ovarian cyst you need to keep it in mind is a dermoid cyst. Please remember.
Dermoid cyst, yes.
Ovarian
asymptomatic dermoid cyst.
Asymptomatic, and they can also present as a torsion and can become big. Just for a completion. So not only when you remove one side, always see other ovary, and make an incision, and you just have to enucleate that whatever that cyst on the other side. Okay.
Can you go to clinical examination, sir?
Yes, yes.
Yes, sir. Yes, sir. Yes, sir.
Shadan, you had...
Yes, sir.
Can we go, sir? Vimal, can we go?
Yes, sir. Please, sir. Please, sir. Okay.
Hitesh, you wanted to answer any question? Okay, please go to clinical exam.
Yes. So moving on to the clinical examination, general examination, the patient was conscious, oriented, afebrile. She was moderately built and her hydration was good. Her weight was 58 kg with a height of 155 centimeter. Her BMI was 24. She was ECOG class 1. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. There was no left supraclavicular lymph nodes. Pulse rate of the patient was 90 per minute, which was regular and good volume. The BP of the patient was 120/80 millimeter of mercury recorded in supine posture in right arm.
Dr. Guru Shankari, just Guru Shankari.
Moving on to the abdominal examination, inspect
No,
down
wait.
the adequate. Yes, sir.
Guru Shankari, Dr. Rajgopal sir wanted to ask you.
You are there?
Yes, sir, she's there.
Yes, sir.
It's difficult to say right or wrong, but remember, supraclavicular node in a abdominal case should be given a separate importance, like one area. Okay. It is not like a generalized lymphadenopathy or something. It is not like a generalized lymphadenopathy in a loose way. No pallor, no icterus, no clubbing, no syndrome, no supraclavicular. At the end of the abdominal examination, you better clearly mention, I have specifically looked for supraclavicular node. Okay, it's better. That's what we generally teach the students. Okay, but it's difficult to say whether the right or wrong. But my personal opinion, I am telling you, it should be at the end of abdominal examination. Yeah, please go ahead.
So 1 second, sir. Can I just add a point to that?
Please.
Yes, sir. Doctor, where will you look for this left supraclavicular node? Hello,
Guru Shankari, she's got poor internet. Guru Shankari, you can close your video if you're feeling.
Yes, sir.
If your net connection is not good, you can close your video. Sir is asking, where do you look for the supraclavicular node?
So clavicle extends from sternoclavicular joint to acromioclavicular joint. So where will you, supraclavicular is something above the clavicle, flat to clavicle. So it is a vague term. Supraclavicular is a vague term. So where will you look for this? So what you are meaning, we can understand. It is virtuous nodes, right? So where will you look for this virtuous nodes? Am I audible to you, Dr. President?
You are audible, sir. Guru Shankari.
Yes, sir.
Are you hearing me?
Your term is supraclavicular. So anything flat to clavicle is supraclavicular node. But what you are mentioning, we are very clear about it. You are mentioning about there is no virtuous nodes, right?
Yes,
so where will you look for this virtuous nodes?
Sir, between the two heads of sternocleidomastoid in the supraclavicular fossa.
Yes, very good. On the median, yes, it is not on the supraclavicular fossa. So it is in between two heads of sternomastoid, just above the clavicle. Fine.
Yes, sir.
Are you clear about that? So that node is called as virtuous nodes, and you got to sign all these things. So when a question is put like this, you should be able to justify what it is. So all supraclavicular nodes are not virtuous nodes, right?
Yeah, Dr. Nithilan, just for my clarification, because
yes, sir.
After
Is Vimal
it is my son. It is my son's iPad.
No. Let us, for the sake of postgraduates.
Yes.
After the Sloan Memorial catering, all that classification, all that medical oncology all came from the time immemorial.
Yes.
In between the two heads of the sternomastoid used to be called as scalene node in the sense.
Yes, sir. Yes.
Typical node of a bronchogenic carcinoma on the left side. That is one. Now I know what you are referring is a 4B, correct? 4B. Supraclavicular node is 4B. Now, many patients with the carcinoma stomach or whatever, they come with quite a significant node, about sometimes 3 nodes, 4 nodes in the supraclavicular region, but it is not exactly in the area of what we are discussing now.
We see, exactly.
Do you call them as supraclavicular or posterior triangle nodes or virtuous site? This is for my clarification, because always a controversy is there.
Yes, sir, definitely.
Can I answer this question?
Yes, sir. Please.
Yes, sir. Please, sir.
Yeah, actually, supraclavicular, when you say supraclavicular region, I understand what you clearly said, that you also have posterior triangle at level 5. So supraclavicular region is actually the inferior border is the upper border of the clavicle, and the superior border is the inferior border of the horizontal thing of the muscle, omohead muscle. That is what is classically described as supraclavicular region. The omohead runs parallel to the clavicle, and you have a what Dr. Shenoy has mentioned, that it is not necessarily always between the two heads of sternocleidomastoid. It goes many times laterally also, and that is classically described as supraclavicular region. That is the horizontal limb of the omohead. Up and down is the clavicle.
Thank you, sir. Thank you, sir. Welcome, Ishwar, sir.
Yes, sir.
Good evening, sir. So I need some more. I want some more clarification.
Yes, sir.
Postgraduates, if any postgraduate say that it is supraclavicular lymph node, so we will all take it as a Treuzer's node in between the two heads. Many times it is so big enough it can go to the lateral compartment of the neck also. As Shanae sir said, it is 3 lymph nodes. But a definition of the supraclavicular lymph node is that nodes in the supraclavicular fossa. They are nothing but the lower deep cervical lymph nodes. The boundary is the lateral border of the sternocleidomastoid muscle and anterior border of the trapezius and the lower border of the clavicle. That is in the real sense nodes in the supraclavicular fossa. They are nothing but the lower deep cervical lymph nodes, which can be there in the level 5, what is said in the thyroid malignancy and other things. Whereas supraclavicular lymph node in the case of a mass per abdomen, we always take it as the nodes, Ucho's nodes, which is there in between the two heads of the sternocleidomastoid muscle. Particularly if the patient is presented with a mass per abdomen, giving all the GS symptoms, we are to take it as a Treuzer's node only. That's what I wanted to emphasize on my PG.
Yes.
Sir,
Yes.
Shanae sir, is it okay? Or,
No,
Yes,
sir.
exactly.
What
We
I
need not confuse the PG, sir. You can,
correct.
sir. So, Rajagopal Shana, sir, you can confirm what is it? What is it?
Sir,
What is
all the things have been discussed, sir. All have been put in their own perspective. But today, in the oncological way of looking at it, it is like if anything is in the posterior triangle, it is not considered as supraclavicular, sir. That's what I think they are trying to say that. Correct?
no,
They
sir, I
Yes,
want
sir,
to
yes.
notes in the supraclavicular fossa. Notes in the supraclavicular fossa.
Sir, they are telling it's a posterior triangle node, sir.
Obviously, yes, they are also called as posterior triangle lymph nodes.
Whereas oncological way is a 4B. That is what even I am
Yes.
as a general surgeon. When somebody with the carcinoma stomach, very often we have seen they are not in the actually in the two heads of sternocleidomastoid
Two
muscle.
heads. Yes,
No.
I do.
It might be in the posterior triangle.
Yes, exactly. Very often. So many times I have seen. And including
Definitely, sir.
so many times, not once or twice. It is never a 4B. It is always in the posterior triangle nodes. That's what is I have seen in so many years. Anyway, sir, that's what is.
Hitesh, sir, you wanted to say something?
No, no, as far as PG doesn't miss examining this region, I think we should be fine.
100%. I fully agree with you. They should know the method of examination and how to examine. This happened after that oncological classification of the level of the nodes, sir. This thing.
Yes, sir. Yes, sir.
Can we?
So another small thing, sir. The
Yes.
presenter, how will you examine this left supraclavicular node? From front or from back?
Guru Shankari?
Yes, sir.
You will examine this left supraclavicular node, what we have been discussing,
Yes.
from front aspect of the patient or from the back of the patient?
From the back.
Yes, good. So only level 1 you will examine from the front.
Yes.
And
Sir.
all the levels you have to examine from the back. Okay. Fine.
Yes.
Yes, ma'am. You proceed with it. Let her finish.
And also, sir, I would like to add that why I said supraclavicular should not be general examination. Most of the time, patient is lying down. You do a cursory and put left supraclavicular hand and say not palpable. But you need to make the patient sit, and you go behind and flex the neck a little bit and relax, and then carefully you go behind and palpate. All that can be done as a separate entity. There should not be even a small half centimeter or even 1 centimeter node. That is the one reason I postgraduate should know that they should examine it properly. Yes.
You can
Yes.
present, ma.
Yes. So moving on to abdominal examination. During inspection, patient was lying down with adequate exposure and proper consent. Abdomen was flat and all corresponding quadrants were moving equally with respiration. The umbilicus was central and inverted. The skin over the abdomen was normal. There were no dilated veins. A healed lower midline scar of size 7 centimeter was noted. There was no visible intestinal peristalsis. The hernial sites were free. The genitalia was normal. There was no fullness in the right iliac fossa or any lumbar region, or the spines were normal. On palpation, with hip flexed, the abdomen was soft, non-tender, and not distended. A mass of size 6 cross 4 centimeter was noted in the right iliac fossa, which was hard in consistency, irregular borders with a nodular surface. The mass had restricted intrinsic mobility in both vertical and horizontal direction. Her liver and spleen were not palpable. Moving on to percussion, there was a dull note over the mass and no shifting dullness was noted toward the abdomen. On auscultation, the bowel sounds were normal, no bruit auscultated. During the digital rectal examination, the stools were normal in staining and there was no mass or deposit palpable. Moving on to systemic examination, a respiratory examination relieved bilateral normal vesicular breath sounds with no added sounds. Cardiovascular system was normal with normal heart sounds with no murmurs. A central nervous system was also normal. So, to summarize, a 52-year-old postmenopausal lady with diabetes presented with right lower abdominal pain for 3 months duration. On examination, she had a hard, non-tender mass of 6 cross 4 centimeter in the right iliac fossa. My provisional diagnosis would be carcinoma cecum with the differential diagnosis of ileocecal tuberculosis.
Presenter, I would like to just have an add a point to you now.
Yes.
So your examination is not complete. You have finished examination of abdomen, all these things, genitals. You just finished it as a genital. You gave a history of vague lower abdominal pain, history of surgery for ovarian cyst, and there is a midline scar, lower midline scar in female patient, and there is a relatively fixed mass. It is not freely mobile mass, relatively fixed mass in the RAF.
Yes.
I voted more in favor of an ovarian pathology. How do you contradict me? So what are the points to say it is an ovarian pathology? What are the points not to say it is an ovarian pathology?
Sir, in this case, we could freely palpate all the borders of the mass. In case of ovarian
Yes.
pathology, we will not be able to pass a lower border.
It is not strictly. So most of the times you won't be able. Sometimes it might be a pelvic-abdominal mass, or sometimes it might be a mass extending completely into the abdomen. So that, and most of the ovarian masses, there will be little mobility, right? So that
Yes.
is one contradictory point, right? Fine. Then another important thing, you didn't do PV.
Yes, sir.
Without doing PV in female, the examination is incomplete.
Okay, sir.
And I've been thinking of an ovarian mass. So the whole history was an ovarian. Suddenly you jumped it as a cecal tuberculosis or cecal mass. You didn't substantiate that it is a cecal mass, and you didn't find any points against ovarian mass. So without pelvic examination, without pervaginal examination, pelvic examination is not complete.
Okay, sir.
Right?
Yes, sir.
So you have to see the pelvic examination. You have to see the fornices. You have to look for the uterus. Fine, whether there is mobility of the mass, or whether you are able to palpate this mass, what you are seeing in the abdomen, high up in the fornix. Are you able to get what my point is?
Yes, sir.
While doing PV, you can feel a RF mass. If it is quite big and extending into the pelvis also, beyond the pelvic brim into the pelvis, you can still feel it through the fornix. Fine.
Yes, sir.
So that point you have to add here. So in pelvic, in peritoneal examination, I'm not able to make any abnormality. It's
Yes.
good.
I have 2 points to tell you, Dr. Gauri. Sorry.
Call us Shankar. Shankar is enough, sir.
One, as sir has put it, you could have easily told that lower border is very well felt.
Yes.
Okay.
Yes,
See, all borders making out is totally different. Especially what we tell is lower abdominal mass, lower border is important. Upper abdominal mass, upper border is important. Is it clear?
Yes, sir.
But you all know, no, finger insinuation and all that thing. So that is one point. And second, the question of ovary versus this was asked. For completion's sake, you could have mentioned that percussion note over the mass, whether it is resonant. Okay. I know that such a big, large, hard nodular mass may not give any much importance, but still, if you have to elicit some amount of percussion note, you can still say that, sir, it could be cecum.
Yes.
Right? It could be cecum because obviously hollow viscous having air or whatever it is. So these are not the mandatory ones, but this is just to help you a differentiation. If the examiner asks you, why don't you put ovary first in this patient? If the question is asked, what is your answer? What is your answer? Suppose, let us say you are not done a PV. So you have a doubt that whether it's a carcinoma cecum, 52-year-old lady, no loss of appetite, no loss of weight, nothing is there. And second is you said about ovarian ileocecal tuberculosis. And third, we are trying to tell you why not a ovary. Now the question that I am going to ask you is, why not any other tumor? Any other tumor? What is your answer?
I said ovary because since the lower bottle was not palpable, I would like to.
Yeah, that we will take it. Even though ovary can come out completely, that's all right. So my question to you is that whether any other things you should consider means anything which is little behind, like a lymph nodal mass, they may exhibit some pulsation sometimes. Is it clear to you?
Yes.
Okay. And a patient like this with absolutely no bowel symptoms and all that thing, you are written so hard and irregular with the restricted mobility. We all believe it is a carcinoma only.
Yes.
For all purposes. But with the no symptoms, examiner will definitely ask you, are you thinking anything else? Then the question of this lymph nodal mass, differential diagnosis and all that will come, right? Okay, yes, sir.
Shadhan, sir. Sergeant, sir.
Okay, sir. Okay, sir. I am there.
Any
Okay,
questions
few
from
common
you?
point I'd like to ask. Sir, like sir said, without per-vaginal examination in a female with lower abdominal pathology, it is definitely incomplete examination. I would like to ask some general question to Dr. Guru Shankari. How will you differentiate or how will you assess the location of the lump, whether it is the parietal, intra-abdominal, intraperitoneal, or intra-abdominal retroperitoneal lump?
So we can do a leg rise test where if it is an parietal wall, then it would the lump would decrease in size.
Right.
Okay, carry on. You are answering about what? It is about the parietal mass, or you are answering about the intra-abdominal mass?
It's about the intra-abdominal mass. So when we rise this, then the mass reduces in size, whereas an parietal wall mass will become more prominent.
Okay. Well, how will you differentiate about the intra-abdominal, intraperitoneal, intra-abdominal, retroperitoneal mass?
Retroperitoneal mass, it could be palpable from the lumbar region better than the anterior abdominal walls.
Not necessarily. All retroperitoneal may not be present laterally. They may be in the central and the lower part also. Per se, if there is a mobility for practical purpose, they are more favorable that the lump is intra-abdominal, intraperitoneal. The retroperitoneal lump usually have a very limited mobility. And as far as the test, this any elbow position test is concerned, that is actually not more of a theoretical rather than it is not advised to be done in all the patients. Though sometimes if the lump is in the central abdomen, there it may be some helpful, but being so inconvenient to the patient, it is not encouraged for the student to do that test. Okay. You said about the position of the hip. Can you tell me what is the relevance of knowing the position of the hip in a patient where you are not sure of the origin of the lump in right lumbar lump, like it may be still from the other organ other than the colon and the ileocecal area that you are considering?
Sir, I didn't get your question, sir.
Is there any relevance of knowing the specific position of the hip, or any test that can help to assess the location of the lump in a patient with the right iliac, right lumbar lump? Are you there?
Will you do any hip flexion or the position of the hip in relation to the lump? Sir is asking. Is that your question, sir?
Okay. Yes, sir. Have you heard of SWAS sign that we commonly speak related to appendicitis?
Yes.
Is it possible
Yes,
to get any kind of deformity or any restriction in other pathology also? Like
You can answer, sir, please. She is not.
okay, like sir said, if you are suspecting a ileocecal tuberculosis, sorry, spinal tuberculosis with secondary ileocecal abscess, there again you can get the same signs. And of course, any retroperitoneal or even the cecal malignancy, if it is infiltrating or involving the psoas muscle, that again it can produce the same restriction or the deformity of the hip joint if there is secondary involvement. And again, and sometimes, of course, if there is a neurological infiltration and the spinal involvement secondarily, there again, it is not specifically that you will get only in the patient with acute appendicitis. That is what I want to say.
Yes.
I may be corrected if my answer is not acceptable to experts,
No,
teachers.
sir.
No, sir.
No, very nicely he has told that it is not the basic thing as a postgrad you should know is anything irritates the psoas. That's all. So typically retrocecal appendicitis, sir has already mentioned to you. And nearest muscle behind the cecum in the anatomical way is iliacus. Okay, iliacus. That's why that iliac artery, the name iliac artery, iliacus, iliopsoas. That is the complex. What sir is told is right. So anything irritating. So TB spine too. All these things which causes that psoas spasm. So that is what is typically you should look for in this type of patient. That gives an idea that where is the most probably the lesion and what is its importance. That's all.
Yes.
Okay. So in the order of priority, what are your diagnoses you would like to tell now? Revising. You do still consider hard, nodular, restricted mobility. Of course, in India, we still bank on tuberculosis, but what is the classical location of a tuberculous mass, ileocecal mass, madam?
Sir, it is more commonly seen in the right subhepatic region because
Oh, don't go too high to subhepatic.
lumbar.
Don't go too high.
Lumbar.
Because pulled up cecum. So what you should, and is it that kind of a hard, irregular, nodular, no fever, 52-year lady? So your diagnosis should tilt more for a malignancy, correct? Hard nodular, ovary, yes, which has ascended into the peritoneal cavity. Lower border, of course, you have mentioned about that. And third diagnosis, nodular mass. No lymph nodal mass will grow to this size, huge ones. Yes, lymphomas are known in the neck for a bull neck, like, huge masses like that. So less likely for such a large mass. And last but not the least, I always think of retroperitoneum. And again, hard nodular, less likely retroperitoneum. If it's a male patient, what else you would have thought of Guru Shankari? Male patient. So no question of thinking ovary, uterus, your headache is not there. So what else? If it is not colonic mass, what else you would consider? You said genitalia important, you mentioned sometimes.
Yes.
What is, you mentioned the importance of examination of genitalia. Is important male or female?
Sir, it's more important in male.
Why?
Any hidden lesions can be there.
Hidden means what is hidden? Be specific.
Any testicular tumor which can present with iliac nodes.
So, and testicular nodes with iliac nodes. See, you are trapped. Testis drains to iliac nodes.
Paraaortic nodes.
So what is that? What we want like is undescended testis with the tumor.
Yes.
You can get a large mass fish. So what you would have told is absence testis. Okay, absence testis. You are
Okay, I would
there?
like to interrupt here,
Yes.
sir.
Please,
The presenter.
please.
What are the anatomical diagnosis you can provide here? You have landed up to a malignant mass. So what are the anatomical diagnosis? What are all the anatomical structures in the RAF region you got? Presenter.
It could be an mass arising from the appendix.
Yeah, that is the next common thing.
Yes.
Next to cecum
Yes.
comes the appendix, and only then all your retroperitoneal, lymph nodal, undescended testis in a male, right?
Yes.
So next common is an appendicular mass. What appendicular mass? It can be
Carcinoid or
yeah.
adenocarcinoma.
It is a malignant appendicular masses. That's the, okay, fine. You cannot find out whether it is carcinoid or carcinoma or mucinous carcinoma. Could be an appendicular mass with some carcinoma in appendix, right? Just like as you say, it is carcinoma of cecum.
Sir, just to tell, sir, not contradicting anything here, sir, because these people, if they say carcinoma appendix or whatever, then the examiners will bounce and say you have seen the report. So what we generally
okay, fine. It is a malignant mass. Fine.
We generally, yes, as she rightly put it, we expect them to think of ileocecal tuberculosis, very common
tuberculosis. Fine.
But in this patient, probably the discussion, because if they say carcinoid of the appendix and all that thing, no, then there is a problem.
They'll think of whether they have seen that. Yes.
So I think Dr. Vikram Kate, you can probably chip in
actually, when it's a right iliac fossa mass at the postgraduate level, they expect 3 diagnoses. Those are the commonest. We can say any right iliac fossa mass, 90% of times the diagnosis falls into only these 3 diagnoses. One is the appendicular mass, which is the commonest. Second is carcinoma secant, that is number 2. And number 3 is ileocecal hyperplastic tuberculosis. As Dr. Vimal has mentioned, that rarely you can have, as I said, mucinous malignancies of appendix. Actually, carcinoid will not give rise to a tumor. Carcinoids are very small tumors. So palpable tumors from carcinoids are very rare. So it will be actually, suppose you have a mucinous tumor of the appendix. In those circumstances, okay. They've asked me to start the video. Okay, in those circumstances, when it's a mucinous malignancy, there can be a lump formation, but that's extremely rare from the appendix. So I would like to put it as these 3 diagnoses accepted in the examination. If it's a short history, appendicular mass. If it's a 3-4 months history, you have to actually titrate between carcinoma cecum and ileocecal hyperplastic tuberculosis. These are the accepted answers at the postgraduate level.
Yes, sir. I agree with that, sir. Exactly, sir.
Can we proceed with the investigation, sir? Management?
Yes, sir.
Yes, how will you manage?
I would like to do a basic blood investigation, such as a complete blood count with renal function test and a liver function test. Since I have my initial diagnosis is malignancy, I would like to do a tumor marker such as CEA levels. And I would also, yes.
Dr. Guru Shankari, I would like to interrupt you.
Yes.
I'm sorry. Can you please tell us, since we are still not very sure because of the only few presenting points in history and examination, what investigation you will do to confirm your diagnosis?
To confirm my diagnosis,
I think tumor marker, is there an indication of doing tumor marker before knowing the diagnosis?
Yes.
Guru Shankari, what sir is telling is, if for some reason, see, we all should not be under the impression that clinically I am excellent. Forget about clinical. Now, after ultrasound, if it turns up ovarian or XYZ, all that your investigation become waste. No.
Yes.
Here, tumor marker and all. So what should be the best way to go ahead apart from blood test? That's what he is trying to tell.
Yes.
What is the thing you follow regularly in wards? That is very important.
Sir, I would like to go ahead with an ultrasound of the abdomen to localize the mass from where exactly it is arising, the extent of the mass, and any other local pathologies. And also I would like to see for any liver and spleen and free fluid.
So, with these two diagnoses in your mind, like ileocecal tuberculosis, cecum, and the third option that again and again has been highlighted is the likely variant pathology, uterine pathology.
Yes,
You
sir.
do not mind to have a look into the pelvis also?
Like to do a pelvic scan also to look for any uterine or ovarian lesions.
So what sir is trying to tell is, in a case like this, yes, I know that this is a examiners expect you to say, sir, I will take a gynec opinion. Is it clear to you?
Yes,
See,
sir.
now we have reached the management part of it, right? So, and nobody will tell you that it's a right iliac fossa mass is cecum or something. This is a different, because we all know that we are discussing cecum. That's a different issue. But in a genuine patient, when it comes to you, we always ask for the gynec opinion, number one. And number two, your answer should be, based on my preliminary ultrasound report, I will order for next investigation. Preliminary. Is it
Yes.
clear? So
Yes.
I think
So,
we should.
I think we are running short of time. To should we give her some situation so
Yes,
that she
sir.
can
Please, sir.
proceed further?
Please,
So
sir.
keeping in mind your first differential diagnosis, and on ultrasonography, there you got a finding of circumferential thickening involving the cecum with surrounding enlarged lymph node, without any evidence of ascites, without any other lesion in the liver or any other part of the abdomen, and then the probable diagnosis of a neoplastic etiology. How will you proceed further?
Sir, I would like to do a colonoscopy for a tissue diagnosis and also to look for any other lesions in the colons.
Go ahead, doctor.
Yes, sir. And I would also do a CCT abdomen, pelvis, and thorax to stage the disease.
To carry on with the
Keep going,
investigation
keep
that you
going.
would like to go
What
ahead.
is that you want to find in CT scan?
Sir, I would like to find the origin of the growth, the extent, whether it is infiltrating the surrounding structures, and any lymph nodes, regional and any distant lymph nodes. And I would also like to see any metastasis such as liver mets, free fluid abdomen.
And you should also tell whether it is causing an obstruction to the bowel. That is also an important thing when you do a CT scan, whether the tumor is partially obstructing or totally obstructing, because their plan and strategy is going to be different when compared to a non-obstructed lesion, right? So that part also should be mentioned. And when you're talking about the growth, you very clearly mention about whether it is infiltrating into the nearby structures or not. But here, infiltration, you also will be expected to tell, being a right-sided colon growth, you also should mention the ureter and kidney status,
Yes.
right? So these are the extra information when you do a CT, you get very clearly. So this helps you to plan treatment, however be the stage. But if it is infiltrating into ureter or infiltrating into nearby organs, your strategy changes. Even though it may not be a non-metastatic tumor, or locally advanced tumors also can be a troublesome one in right-sided colonic tumor. So please add those additional points when you're talking or when you're arriving at your specific diagnosis. All right.
Yes, sir.
And how do you do a colonoscopy? Is that a very straightforward thing to prepare this patient? How do you prepare in your department? How do you prepare a patient for colonoscopy?
So in a non-obstructed patient, we would prepare the colon with peg leg the evening before the day of colonoscopy, and then we would keep the patient NPO. Then we would proceed with colonoscopy. So the next,
Dr. Guru Shankari, what does peg leg contain?
sir, polyethylene glycol. It is nothing but starch kind of material which will increase the which will lead to loose stools and clear all the sediments in the colon.
So my question is not to test your always in the MS examination, try to avoid these names of PEGLEC, etc. like that. Is
Yes.
it clear? You
Yes.
can straight away tell the generic, including even for the drugs, cephalosporins, metronidazole, like that. You better use the words rather than using, so that you will forget actually the original name.
Yes.
Shankari, please proceed on. You have a platform with Dr. Shadan Ali sir has very clearly said it is a cecal growth, locally limiting. With that, what is the type of management? You have pre-optimized the patient, you have stabilized the albumin levels, you have corrected the hemoglobin levels being a right-sided lesion. Patient is fine and fit, you have got an anesthetic fitness. What is that you want to do?
Sir,
Vimal, you want to add any points? Or shall we go for the Vimal Kannan?
Sir, they have arrived at an anatomical diagnosis of cecum.
So
Fine,
they-
it is a right colonic mass, whether it is tuberculosis or some mass in the right colon. So definitely now here comes the role of tumor markers. You have to do a carcinoma embryonic antigen level. That is mandatory. Fine. So without CEA in the preoperative setup, you cannot take the patient for a surgery. You should have a baseline CEA. Though you have a diagnosis of anatomical diagnosis of cecal mass or right colonic mass, and you've done a colonoscopy, you've taken a biopsy, and the biopsy is proved. Even though you have got a proven adenocarcinoma of cecum or right colon, it is mandatory to do a CEA. Right? It should be a baseline CEA level for future prognostication and future monitoring the recurrence. So this is the point I would like to add on here. So sir was telling that instead of doing CEA at the first set, taking a blood sample and sending for CEA all the markers, you localize the lesion, whether it is from cecum or ovary or from whatever it is, localize by imaging. And after imaging, you do a scopy and do a biopsy. After that, you have arrived at an anatomical diagnosis and pathological diagnosis. Then here comes the tumor marker levels. Fine.
yes.
And we have Professor Ajay Khanna sir. I think it was my mistake not informing on time. Thank you, Khanna sir, for joining us. Professor Ajay Khanna is a professor of surgery from Banaras University, Varanasi, and our long-time contributor and as a faculty. Thank you, Khanna sir. Guru Shankari, please proceed with that discussed upon. What is the treatment option you have in hand?
Sir, with operable carcinoma cecum, I would like to go ahead with right hemicolectomy and iliotransverse anastomosis. And based on the post-op biopsy, I would decide on whether the patient.
Please wait.
Try to answer in your patient. You only said it's fixed and hard, some irregular fixed, something like that. You are talking. So patient does not have obstruction features at all in your patient. So what you should have told is, I will do the CT scan and assess. If it is fixed to the posterior structures like ureter, what your patient would have had, you please tell me. It's obstructing the.
If it is obstructing the ureter, then the patient would have had an obstructive this HUN, hydroureter nephrosis can
So
be.
what you would have done at this stage now?
So I would have assessed for the function of the contralateral kidney.
No, function of this kidney also. Okay, contralateral. That CT scan is there. Anything else? Anything else? More important.
Do a cystoscopy and do a DJ stent.
So just you have to say that ureteric stenting. That's so okay. You are done a ureteric stenting. Examiners want to know the patient has no obstruction. Since you are told the clinical mobility. See, what you are talking is clinical.
Yes.
CT scan findings may turn out to be operable only. Is it clear to you? So yes. Inoperability at a surgeon's angle is different from clinical versus operable in a surgeon's hand as he explore. So I think Kanagavel sir, I think she should be given a like if it is fixed to ureter, what will you do? Perfect. If it is fixed to something like that, I think
scenario based.
Yeah, I think so. Yes, please give sir. Please.
Shankari, have you operated on this patient?
Yes, sir.
Patient,
Yes, sir.
Operated?
Yes, sir.
Okay, can you tell, you were in the part of the surgical team to?
I was in the managing team, but I was not intra-ops.
Did you go through the operation notes written by the resident there?
Yes, sir.
Can you tell the finding, what was
Correct.
seen in the operative period?
Yes, sir.
What has been done to your patient in this scenario with this clinical fixity, right?
Yes. Intraoperatively, there was no intraoperatively on assessing. There was no omental or deposits or liver surface was normal, and the mass was mobile, sir. So they have done a right hemicolectomy with iliotransverse anastomosis.
So why did you tell it then it is fixed? So you need to, you said fixed, no? Correct?
Yes, sir.
Or is it mobile after the dissection?
Did you say fixed or you said restricted mobility?
Restricted.
Answer properly.
Okay.
Restricted mobilities.
So say that. And also.
So I'm just, I'll just ask another question to the presenter, sir.
Please.
And for all the postgraduates, presenter, you said the tumor is limited. You didn't say the extent of the tumor. That you, for your sake, I'm just taking it as tumor is limited to cecum. Fine. And hepatic flexure is normal. Is that so? Fine.
Yes.
Right. Is that so? Fine.
Yes.
And
Sir.
how about the ileum? How about the status of ileum, distal ileum? It is normal.
Ileum was not involved.
Not involved. So
Yes.
where was the bowel resected? What is? I'm just trying to figure it out. What you know about right hemicolectomy? What do you know about colonic surgeries? Just basics. I just want to touch about the basics of it.
A lateral to medial approach.
Put it another way. Why do you want to put it? I'm not asking about the approach. Just a pinpoint. See, why do you want to remove the whole of right colon and right side of transverse colon, distal ileum, when the tumor is just confined to cecum? In a case of stomach cancer, when the tumor is in the antrum, you just give 2 centimeter margin distally and 5 centimeter margin proximally, right?
Yes, sir.
You know that? Fine. So, and the same holds good for a small bowel carcinoma also. You give some 2 centimeter or 5 centimeter margin. So, why don't you give some 5 centimeter margin? You give 5 centimeter margin from the ileocecal junction, take just 5 centimeter of ileum, and 5 centimeter margin from the cecum, you just take 5 centimeter of extra right colon. And you can do a, very well, you can do an ileo, you need not go for iliotransverse anastomosis. You can do a ilio right colonic anastomosis and can preserve some of the bowel.
Sir, in case of
everyone knows what I'm saying is not practice, right? You know that what I'm saying is not practice. I just wanted to substantiate that. Why it is not being practiced? Why do you want to remove the right colon, ileum, distal, proximal transverse colon in a case of tumor which is confined only to cecum?
Sir,
that is my question.
Yes, in colonic malignancy, there is high likely of nodal mets along the vascular structures. So we would like to ligate any common vascular supply, like from right colic, we would like it so to achieve adequate clearance.
See, what you are trying to say is explanation. Just have it in a single word, right? For any primary pathology, the resection is based on the lymphatic drainage also. Right?
Yes. Yes.
If it is a distal antral cancer, you confine your resection to all these lower nodes and N1 nodes, all these things. If it is a colonic malignancy, right colonic malignancy, all these lymphatics go along the vessels. Okay. Yes. So if it is a cecal malignancy, where will you have the lymphatic drainage? So basically, any colonic resection is not based on anatomical position. That should be your answer. It is based on the lymphatic drainage. It should be very clear, right?
Yes, sir.
So any colonic resection is based on lymphatic drainage, not on the anatomical position, right?
Yes.
On the anatomical position alone, fine. It is based on the lymphatic drainage, right? That is what you are trying to tell in other ways, like getting the main vessels and like getting the vessels, taking out the lymphatics, right? Fine. So where will you transfer the colon, transverse colon?
Sir, we will be ligating the right branch of the middle colic, and we would transact almost 2/3 of the transistor.
It is not almost, all these adjectives are not there. It is exactly very clear in that. Fine. You ligate right branch of middle colic, ileocolic, and right colic. Fine.
Yes.
And what is the reason to remove the distal ileum?
So because since we are ligating the ileocolic, initial the distal 20 centimeters is supplied by the ileocolic. So the be loss of.
It is not 20, I think. I think it is only 10 to 15.
10, 10.
Yes.
Yeah, it is not 20. Yeah, fine. You should be clear about that. Fine.
Yes.
That's good. Okay.
You know the problems of
structures-
removal of too much of the ileum? You know the problems of removal of too much of the ileum? So you should not remove 20. Okay.
Yes.
Okay. What structures you will look for when you do for a right colon colectomy? What structures you will preserve? 1, 2, 3. That's all. Only up to this you will be asked. In any colonic surgeries for a MS graduate, only up to this you will be asked. What is the concept behind removing this colon? Then
But sir,
what parts will be removed? Then which structures you will preserve?
but she has started from left to right, sir. Mobilization. That's fine. That's fine. Nothing
fine.
wrong in
So,
that. Nothing.
so you have
answered
to
this question.
preserve ureter, IVC, and duodenum. This is, you have to be crystal clear in that. Ureter, IVC, duodenum, right?
Duodenal injury. Okay.
Injury. Yes, you have to preserve. You should safeguard these 3 structures before proceeding for resection.
Guru Shankari, what are the most common troubles in the post-operative period? If you can list 1, 2, 3 important post-operative issues.
Yes, sir. It can range from local to systemic complications. The patient can have local complications such as any anastomotic leak. Then patient can have superficial to deep surgical site infections, and systemic complications such as patient can have basal atelectasis, and she can also have DVT, deep vein thrombosis.
If I'm going to ask you and limit a question to what are the anastomotic complications, what will be your answer?
Sir, in acute setting, there can be anastomotic leak. Later on, the patient can have any anastomotic stricture. And
leaks and the delayed strictures are the common things you may face. And if somebody is going to challenge you on very late complication, I won't tell it's a complication, anastomotic site recurrence. These are the 3 things you should keep in mind in anastomosis when you are asked about a specific question.
Yes.
I think we are fairly okay. Let me make life easier for you. Your post-operative biopsy report comes as all resections, radial and proximal and distal margins negative. 8 of 22 nodes positive for malignancy. The most proximal node at the vascular origin is positive along the middle colic vessel. What will be your approach now? Tumor is a well-differentiated tumor.
I would go ahead with an adjuvant chemotherapy for this patient with 5-fluorouracil, purulinic acid, and
okay, let me here. Vimal sir, can you briefly sum up this thing, because I need to move to the next case. So I would say, what will be the optimal adjuvant therapy for this patient?
Sir, you said it is a 8 nodes positive.
Yes, sir.
So definitely we'll have to do a CT chest if it is not being done preoperatively. And after that, nearly around, we have to wait for nearly 4 to 5 weeks for the anastomotic site to heal and for the patient to pick up his general condition. Then if the patient is otherwise fit, the ideal regimen is what she said is FOLFOX, 5-fluorouracil with oxaliplatin, once in 2 weeks for, it goes up to 12 weeks. 12 sittings. So it should be 6 cycles. Once in 2 weeks constitutes 1 cycle. So day 1 and day 15 constitutes 1 cycle. And like that, it goes for 6 cycles. Totally 12 times it will be given. This is the ideal one. If it is multiple node positive. Yes, sir.
Thank you.
And if it is just like that, 1 or 2 nodes positive, you can just limit the regimen to oxaliplatin and capsaicin. And that has to go for 6 cycles. This is the common thing. And for this postgraduate level, they won't ask these how many cycles and what is the dose. You just mention the drugs that is in a 5-FeNO oxaliplatin or oxaliplatin with capsaicin. Both these are good. You just stop with this. Fine. And you don't get into trouble by answering too much of what you don't know. Fine. This is a good presentation. Then one more thing to add up here. How will you follow up the patient?
I would be doing a 3-monthly CA levels for the initial 2 years. And
you start with 3 monthly clinical examination.
By 6
First thing is
monthly
clinical examination,
5.
then CA, fine, all this is colonoscopy. Everything good.
Yes.
Will you do a PET scan frequently?
Yes.
Will you do a PET scan frequently?
When there is a serial.
Yeah, when there is a rise in CA level, yes. Need not be higher than the normal. When there is consequent serial rise in the CA level for the past previous 3 or 4 values, you will go for a scan, colonoscopy and a scan. Fine. Good. It's quite a good presentation.
Yes.
But
Sir Shadan sir, you would like to add any comments, sir?
Yes, sir. Dr. Guru Shankari, very nice presentation. And of course, the sir has summarized well about the adjuvant part as well as the follow-up. My last question I would like to add and ask, as sir asked about the PET CT scan in the follow-up as a period. Is there any indication of PET CT in a pre-operative part? If there is an indication before surgery?
In the CA levels are very high.
Okay.
We are suspecting any myths, which is.
So what actually some guidelines say
we can do a PET.
Okay.
Sir,
I would like to add.
Shall I add a point here, sir, to just end up this confusion in this scenario?
Please.
So if the CA level is high, all these things are not so relevant. And there are some tumors where colonic tumors also, in which the CA will not be raised. See, if you find it is a locally advanced colonic malignancy, like it has got multiple nodes and large nodes and parietic nodes, and in that scenario, you have to go for a CT chest. HRCT thorax is more than enough. And if you have any suspected or a doubtful indeterminate pleural, subpleural nodules or doubtful mediastinal nodes, then a PET CT is indicated. Fine. So you just find out whether there is activity or not, and there is no modality to prove that by a needle or something, PET is indicated. Other than that, a good CECT abdomen and a HRCT thorax is more than enough. Because colonic malignancies, they just metastasize within the abdomen, and next station outside of abdomen is just a lung or mediastinum and a supraclavicular node. And it is not always, PET is not always required. And not even in the follow-up also. Fine.
Thank you, sir.
Can I add a point
is it
here?
Okay, sir? Yes, sir. Yes, sir.
The indication for PET scan is what is described as what Dr. Vimalkandan said, that usually not used when you have even high preoperative CA, but when you have very high preoperative CA and conventional investigations, cross-sectional imaging does not show evidence of metastasis. That is an indication for PET scan.
Fine. That is also.
And the same thing is in the post-op phase when there is serial rise of CA.
Yes.
Conventional investigations, they show recurrence, there is no need to do PET scan. But if conventional investigations are normal, including colonoscopy to see for anastomotic site recurrence, if everything is normal, then we have to rely upon PET scan to find out why the CA is rising.
CA, So when there is a serial rise in CA, as sir has been
conventional
saying,
investigations are not showing evidence of recurrence or metastasis, then we should depend on PET scan to find out what is the cause for that rise.
Fine. Exactly.
If the PET CT shows then some deposits there, then what is the management? Will you add into the another cycles of chemotherapy, sir?
So it is not
No, then
adding
yeah,
another cycle.
Sorry, we can continue. Yeah.
It is not adding another cycle. If the patient has already a node positive colonic malignancy and they are being given chemotherapy, some good FOLFOX, all these things, and the patient is under follow-up, you have a serial rise of CEA, and what we are discussing is a PET CT has revealed some deposit somewhere, whether it is in the lung or liver or somewhere, peritoneum somewhere. Then if it is obvious when the SUV is very high, then naturally we have to go for a chemotherapy. Usually it will be with for not with an oxaliplatin. If it is high volume metastatic disease, it will be fall free. Oxaliplatin will be replaced by irinotecan. Usually that will be the thing. And sometimes we will have to do all these additional studies like some other studies, that is not related to these postgraduates, and you can add for a bevacizumab and all these monoclonal antibodies along with irinotecan. That is beyond the discussion for a postgraduate level. So I didn't want to go into that thing. Thanks.
Sir, just
since we brought the role of a PET CT when the conventional CT has not shown up, that's why I brought into the discussion of this.
Yes, sir. Yes, definitely, sir. Thank you, sir.
Sir, just I would like to take an opinion from the panel, sir. How, sir? Is there, sir, any role of PET scan when you are planning for synchronous metastatectomy in advanced stage, like suppose single, say, liver metastasis along with the early resectable colonic malignancy? Is there any role?
Yes, sir. Yes, sir. Definitely, we will have to do a PET before you are planning for a secondary metastatic resection, metastasectomy, because we have to rule out tiny lesions in lung or some other way, because we are contemplating a major resection, and that should be a curative resection also. You cannot go for a palliative because you are resecting the primary and you are planning for a simultaneous resection of secondary also, or the after chemo, whether you are doing it before chemo or after chemo. You have to rule out that your procedure is going to give a good survival or prognostic betterment for the patient. And you have to rule out all these other deposits elsewhere. Definitely there is a role for PET CT in that scenario, sir.
Okay, sir. Thank you. Thank you very much, sir. Thank you from that. That is all from my side, sir.
Yes, sir.
Kanna sir, your comment, sir.
Kanna sir is muted.
Kanna sir is having some connectivity issues, I think. Kanna sir, with the yes, sir, please, sir.
There is some, I think, connectivity problem is there. Gurushankar, I just want sound for any abdominal malignancy or you are doing the CT scan, you should always remember TNM. And based on the TNM you have to look for the tumor, you have to look for the end nodes, and you have to look for the metastasis. So if you keep this thing in mind,
okay,
first I am going to look for that particular tumor which is there. What is the characteristic of that particular tumor? What is the infiltration of that tumor? So if you keep that in mind, in that order, you will not miss any finding on the confusion about that whether it should be 10 centimeter terminal ileum or whether it should be maybe 15 centimeter. It only depends upon once you ligated the ileocolic artery, which is occurring. It may be just 5 centimeters, so you may have to remove only 5 centimeters for that. Or it may go up to 15 centimeters, you have to remove the 15 centimeters for that. Then I think there's a concept of total mesocolic excision which is there, just like we had the mesorectal excision. Similarly, the total mesocolic excision concept is there, and that you should follow. And you should have a policy in your mind if there's a colorectal tumor is there with liver mass are there, then what will be your policy, or it should be synchronous variety. So all these things has to be kept in a patient where you're suspecting a patient of the carcinoma of the colon. Thank you.
Thank you, sir. Dr. Gurushankari, do you have any questions to be clarified or any doubts to be clarified in this forum?
no, sir.
Thank you, Dr. Gurushankari. On behalf of the faculty, I thank you for joining us today. And I also should thank Professor Vikram Kate for giving the PG for the class presentation. Thank you, Professor Kate, sir. Thank you, Gurushankari.
Thank you.
Now, with the permission
Thank
of
you.
the faculty, we move on to the next case by Dr. Apurva Saxena. Apurva Saxena is from Lady Hardinge Medical College, New Delhi. He is contributed by Professor Sudipta Saha from the Lady Hardinge Medical College. So Apur, can you please switch on your video, try sharing your screen and start your presentation.
Yes, sir.
Good evening, Apurva.
Good evening, sir.
Yeah. Go ahead, Apurva.
Good evening, all. Today, I will be presenting a case of penile ulcer. I am Dr. Apurv Saxena, PG third year, Lady Hardinge Medical College, New Delhi. I want to thank Dr. Sudipta Saha to give me this opportunity to present the case on this forum. I am presenting a case of 68-year-old Hindu gentleman, resident of Delhi, who did not receive any formal education and farmer by occupation, who presented to surgery OPD with chief complaints of ulcer over penis from 3 months and swelling over bilateral groin from last 15 days. History of presenting illness: patient was apparently well 3 months back when he noticed an ulcer on the dorsal aspect of the shaft of penis of size 3 by 3 centimeter, which gradually increased to the present size of 6 by 5 centimeter. 2 other small ulcers were also present ventrally. Ulcers were not painful. Ulcers were associated with discharge from last 2 months, which was yellow in color, occasionally blood-stained, and throughout the day, dressing was soaked. Patient also complains of double streaming of the urine from last 1 month, mostly through the ulcer on the shaft and a little from the urethral meatus. Patient also complained of bilateral groin swelling since 15 days, of which right side was 3 by 2 centimeter and left side was 2 by 1 centimeter in size. Both swellings were not associated with any discharge, pain, or skin changes over the swelling. There was no history of blood in urine, acute urinary retention, scrotal swelling, wound over scrotum, any skin lesion, perianal lesion, any abdominal lump, or there was no history of chronic cough, hemoptysis, bony pain, or jaundice. In past history, patient was diagnosed of diabetes mellitus after the admission, and there was no past history of TB, hypertension, asthma, or previous surgery. Patient is married with 2 children. Patient is a non-alcoholic and non-smoker, and there is no history of circumcision or any high-risk sexual behavior. Patient takes a mixed diet, have normal bowel habit, and normal sleep pattern. So can I proceed with clinical examination?
You wait, Basar will ask question.
Dr. Shadan, Dr. Vimal.
So what do you mean by this high risk sexual behavior? Anything you categorization for this high risk sexual behavior or low risk sexual behavior?
So the high risk sexual behavior means that patient has multiple sexual partners, or he has a tendency of he got his sexual intercourse at the early age. These are all the risk factors for the CA penis.
Okay. So is there anything like low risk sexual behavior? So your categorization is something.
I don't know.
Something provoking some questions from the examiner side.
Okay.
So you can coin it in some other way. I don't know how to coin it. No abnormal sexual behaviors, or no extramarital contact, or no premarital contact. You can just put it in a simpler way.
Okay, sir.
That's fine. So what is this? You put some Karnofsky score. What is that Karnofsky score? Is it all important here? So where do you put this, all these ECOG scale and Karnofsky score? You just say it routinely in your exams?
So here we
if you just put it routinely in your exams, you will invite more and more problems. This is a short case. This is a short case, right? You will be inviting more and more questions apart from your topic. So I don't know how the examiners like or not. Just be within your limits. You are presenting an MS postgraduate exam, fine, and a short case. Right.
They are
One more.
presenting as long case, welcome, huh? So they are putting
Okay, sir.
everything. And they are
Okay,
putting it
sir.
as routine. There's nothing,
Routine,
but
okay,
it's a short case.
okay.
Pura is not needed, okay?
Okay,
Yes, Ishwar, sir, please.
Sexually transmitted disease per se will not add on to the malignancy. So is it necessary to ask the STDs?
Sorry,
Sir,
sir?
let the presenter answer now.
Yeah,
Fine. Then I.
no, I wanted the presenter only, sir.
Yes, sir. Yes, sir. Yes.
History of sexually transmitted diseases like syphilis and gonorrhea, are they not? They are not going to add to your diagnosis if you are putting a possibility of a malignancy. So probably not necessary. Multiple sexual partner which is produces some human papilloma viral infections in the form of wart. They could be a pre-malignant. The history of you have to ask that rather than asking the sexually transmitted disease like syphilis and gonorrhea. They're not going to add to your diagnosis.
Okay, sir.
Kanna, sir?
I was telling that because in the DNB examination now there is nothing like the cases. Okay, they are given four cases for the DNB. I'm not talking about so that is why the students they give importance to all almost equally. But I also do agree that in the short case all these things should not be there. Now, Purva, can you tell the chance of having the CS cervix in a partner?
Sorry, sir, I didn't ask that.
So you find some common etiology in what in your case and sir's question?
No, what do you think?
About,
Is
you
an
find some common etiology as common factor? May not be an etiology, common risk factor, common agent.
So human papilloma virus can cause CA cervix as well as CA penis.
Okay. You should know the subtypes causing penis and subtypes causing
So
warts and
the
subtypes causing all these things.
HPV
So it's all
6 and
theoretical.
11.
Fine. It's all theoretical.
Yeah.
It's all theoretical. You have to know all these things. You will be asked sometimes. You should know just HPV is that the answer is HPV. You should be aware of that. That is the thing they would like to ask.
Yes.
Fine.
Hello, Dr. Apurva.
Which
Good evening.
HPV infection
Good evening,
is,
sir.
there are so many HPV infections which are there.
Yes, sir.
So other than risk factor for
Which HPV infection is for the CA penis and CA cervix?
So the
No, which
HPV,
variety? Which
sir,
type of the HPV?
So the HPV 6 and 11.
HPV 16 and HPV 18, है ना?
16 and 18.
16 and 18 जो है.
16 and 18, yes, sir.
Dr. Shadan, your question, please.
Yes, Apurva, as you were saying that HPV and sir has specified that 16, 6 and 18 may be related with the risk of carcinoma penis malignancy. Is there anything else in relation to outcome that it affects presence of say positive antigen per HPV as compared to the non-HPV person? Like oropharyngeal cancer, we divide into two, the one with the HPV positive and similarly the non-HPV positive two category. Is there any importance of or any difference in outcome in the patient who are say positive for P16 HPV viral status versus those negative in outcome?
Sorry, sir, I don't know this.
So they says that they have a favorable prognostic as compared to those with non-HPV. So other than the HPV infection, what are the other common risk factors for say penile carcinoma, and is there any of them is present in your patient?
So the phimosis is a risk factor, and smoking, then abnormal sexual behavior, then these are the common risk factors for the CA penis.
See, again, you are emphasizing about the abnormal sexual behavior, sir. As again told you, be specific. It probably predispose more to the related risk factor that might later on turn you. And other than HPV, HIV itself is a risk factor. And the local pathology that you are not telling, presence of any chronic inflammatory condition, melanitis, melanoprostatitis, all those things.
Melanoposthitis, and
So don't stick to one or two things. Keep in mind what are all factors that can occur. Is there any of them are present? Again, don't emphasize too much upon the personally sexual behavior.
So in fact, balanitis and balanoparasitis, all these things are more common than any of your abnormal sexual behaviors.
So he just, I think, got carried away with the few things. Okay, carry on. No more question from my side.
Can you tell what are the various pre-malignant conditions for the CF penis?
Yes, sir. Yes, sir. So there is yes, sir. So there is balanitis xerotitis obliterans (BXO). Then, sir, erythroplasia of curate, bovinoid papulosis, and so rarely leukoplakia can be present, which can lead to CA penis.
Are you sure that BXO is a pre-malignant?
So it sporadically leads to SCC.
Please refer once again. BXO, benign genetic obliterans, is not considered as a pre-malignant. It is a small, thin validity, pinkish, this one. So usually it doesn't have tendency to go for malignancies.
Pages
BXO.
is there. It can be the Pages disease also.
Yes.
Okay. BXO is also Pages is here for the CA penis. Go ahead with the examination.
So the patient was examined in a well-lit room after acquiring proper consent. Patient is well oriented to time, place, and person. Then BP was 110/70 millimeter of mercury, pulse rate 88 per minute, respiratory rate 16 per minute, temperature 97.5 degrees Fahrenheit. BMI was 22 per kg per meter square. There was no pallor, icterus, cyanosis, clubbing, or pedal edema. There was no generalized lymphadenopathy. Regional lymph node I will be discussing with the local examination. So in local examination, on inspection, penis is grossly edematous in the center, and 3 ulcers are present on the shaft of the penis. On dorsally, a hard oval 6 by 5 centimeter ulcer, 2 centimeter from root, with raised everted edges, and floor is covered with slough and pus, and foul-smelling yellow discharge was present. Occasionally bloodstained. Marked induration present at the edges, and surrounding skin appeared indurated. On ventral surface, 2 ulcers were present, 3 by 2 centimeter and 2 by 2 centimeter, which was well-defined margin with everted edges and floor with minimal slough and no blood. And so on palpation, dorsal ulcer was non-tender, fixed, and was invading deeper tissue, was friable, and was bleeding on touch. Edges were markedly indurated, and surrounding skin was also indurated. And ventral ulcers were non-tender and fixed with everted edges, and induration was present. So papules cannot be reduced, and external urethral meatus was not visualized. Perineal urethra was normal on palpation. On asking to micturate, most of the urine passed through the ulcer, and scrotum was normal in shape. Median raphe was central. There was no sign of erythema, ulceration. So in bilateral inguinal region, right side, there was a single lymph node present of 2 into 1 centimeter, mobile, firm, non-tender, and overlying skin was normal. And on the left side, single lymph node, 1 by 1 centimeter, mobile, firm, non-tender, and overlying skin was normal. DRE was normal, lower limb was normal, inspection of lower limb was normal, and there was no edema present. On per abdomen examination, it was soft, non-tender, liver and spleen were not palpable, no other lump was palpable, CVS, CNS, and respiratory system were normal. So my working diagnosis will be CA penis with bilateral inguinal lymphadenopathy with urethral involvement with type 2 diabetes mellitus, stage T3 and 2 M0.
Shadin sir?
Okay, Dr. Apurva, nice presentation. Can you tell me the few causes of the penile ulcer other than neoplastic etiology, and why do you think this is a case of a malignancy?
So the other causes of penile ulcers are the sexually transmitted diseases like gonorrhea, syphilis, herpes, lymphogranular venerum, and sir, I think this is a case of CA penis because there is a short duration of history, and patient is an elderly gentleman, and so there is a urethral involvement, and ulcers are fixed to the deeper structure.
So in respect to benign versus malignant disease, what is the one finding that differentiate between a benign to a neoplastic etiology?
So fixity to the deeper structure.
In other sense, what does this fixity means? Sometimes secondary to inflammatory changes in resolving phase with fibrosis and healing phase, there may not be much of the mobility. But what actually this fixity is secondary to what? What is the term, word used for this? It is invasiveness. It is the infiltration or to the other structure. So you said deeper structure in the, not deeper structure. What do you mean by deeper structure in your patient?
So the deeper structure in my patient means corpus spongiosum, corpora cavernosa, urethra in my patient.
So what do you said some finding in the deeper structure? What do you mean by deeper structure? How does it affect the management part?
So if the deeper structures are involved, then we have to go for the partial or total penectomy depending on the location.
You are saying it is a stage
And
3 T3 disease. What do you mean by T3 by recent TNM classification?
See,
So in recent
presenter,
TNM
this
classification,
TNM classification, presenter, I just would like to interrupt here. The TNM classification is clinical or pathological in penis?
so the T staging is clinical, and N staging is the clinical and pathological.
So
Both are given.
you are able to make out whether it is involved invading corpus spongiosum, subepithelial layer, and urethra with your hands and your macroscopic eyes. So you don't need any modalities. All these things histopathological. See, it is penis. It is naturally pathological classification. You need not say the staging. Only if you are prompted, you can say more probably it is a deeper situated lesion.
Okay, like
Fine.
sir said, what adjunct? Sorry, Dr. Apurva, what adjunct that you can use to assess the depth of invasion in plasma?
Yeah. Adjunct modality, sir.
Sorry, sir, I didn't. Okay, sir. I can go with biopsy, edge biopsy or punch biopsy to assess the deeper, matlab, assess the stage to know the staging, sir.
No, sir's question is different. Sir's question is different. Sir is asking, penile staging, penile carcinoma staging is pathological or not clinical. If you want to just make it out, what investigation you will do? That is what sir is asking. How will you confirm your invasion of corpora, all these things, before pathological diagnosis? MRI sometimes will help you. MRI of penis will help. That is what sir is asking.
Okay.
And most of the time, urethral meatus, it won't be involved. The tumor might be covering the meatus, and it won't be involving the urethra as such. So urethral involvement, you just think it is in meatus involvement. Just the urethral meatus is just in close proximity to the tumor. You don't take it as it is involved. It is not the urethra. It should be a pathological involvement. Urethral mucosa or urethral epithelium has to be involved. Only that will be classified as urethral involvement. In this, you have to revise your diagnosis as carcinoma of penis with bilateral inguinal lymph nodal involvement or lymphadenopathy, whatever it is. And urethral involvement, it is always a pathological involvement. It cannot be a clinical or MRI, right?
Okay.
You might have splaying of urine, or urine might pass through the tumor because the tumor is naturally in the penis. It will naturally grow into the tip. It will naturally grow over the urethral meatus, and it did not involve the urethral mucosa. Right?
Okay.
Good, very good. Fine. And you have to remove the staging also. It is a pathological
Okay.
staging. Fine.
Okay.
That's good.
Even for clinical staging for TNM, it does not only confine to the history and physical examination. It includes most of the radiological investigation.
Radiological.
I think sir will be able to tell it in
Yes, sir.
further.
Yes, sir.
And
Yes.
other than say some nuclear studies that has not been included, still as a part of TNM staging, even for clinical staging.
Yes, sir.
Okay, that is also.
Okay, sir.
So how will you proceed in this patient?
So in this case, I will first like to get the blood investigations done, and then I will like to get a biopsy of to know the type of the carcinoma, and then sir I will like to get a CT scan done, CT abdomen plus pelvis, to know whether the deeper the lymph nodes are involved or not involved. Then according to the status,
So
then
what deeper node you will expect in a carcinoma of penis? You are not
sir,
sure about your superficial nodes also. So you just said 2 by 1 centimeter node, it is mobile, and any 2 centimeter node in inguinal is not always metastatic.
so
And short axis
50%
only
of
1
the
centimeter.
time
Yes. Yeah, it may be due to because your
reactive,
penis is
sir.
grossly inflamed and there is gross edema in that. So naturally that can be a inflammatory node also. So before
Yes,
your inguinal node is metastatic, it won't go for the iliac node. Right? And your answer is
Yes, sir.
correct. You have to look for a contrast CT. You have to look for inguinal node and iliac node, then
And
parietic node, then
pelvic,
for liver. It is all
yeah.
quite rare. Carcinoma of penis involving parietic liver was all quite rare. So only two things you look for, inguinal and this. Next question,
Yes, sir.
you said biopsy from the lesion. Fine. Will you do an
Yes, sir.
FNAC from the inguinal node? You got an equivocal
Uh,
inguinal node here in this situation. It's only 2 by 1 centimeter. And you're not definite whether it's metastatic or not. Will you go for an FNAC? Because it is readily
sir.
available. You can do it at your outpatient procedure clinic itself, and you can get the results in 1 or 2 days. Will
So I
FNAC
will
is
like to get
indicated?
the
Will
FNAC.
FNAC be useful, and is FNAC indicated?
Sir, in case of bilateral inguinal lymphadenopathy, FNAC is indicated. If it comes out to be negative, then we have to proceed with the superficial bilateral superficial inguinal lymphadenopathy, and it has to be sent for frozen section.
See, this
And
is a quite problematic question. FNAC positive can be taken, fine, but
yes, sir.
FNAC negative cannot be taken. So that should be your
Yes, sir.
clear-cut vision. And
Okay,
and FNAC, it should be ultrasound guided FNAC, if at all you do. Fine, that is.
yes, sir.
And more than that, you don't commit FNAC in the exams. That is a better way to escape. If somebody asks you, how will you manage the nodes? I'll go for it, unless it is a clear-cut metastatic node, clear-cut metastatic by clinical or a radiological. I'll just go for a, if it is not, if it is an N0 clear-cut, no, N0 status, you'll go for a, whatever you said, superficial block, then proceed with frozen. If the frozen is so and so positive, you go for complete block. Frozen is negative, you just close it. That is the way. You don't, all the time you don't opt for FNAC unless the examiner asks. Right. That
Is there
stands
any
good
role
in
of
us. Yes, sir.
is there
Yes,
any
sir.
role
Yes.
of sentinel node in the carcinoma penis in the?
So there are many roles, but this is, see,
So,
for a postgraduate level, even we have faced the same difficulties when we are doing postgraduate in MS. We don't know what to say in exams. Most of the time we'll be stuck with this. You got a obvious penile cancer, and you won't have a metastatic inguinal node. If you say FNAC, you will be caught, and if you don't say FNAC also, you will be caught.
What about
That
sentinel
will
node?
be
They'll not ask.
the
No,
sentinel
no,
node
no,
will be
sir.
failed.
Yeah,
He will
definitely.
be failed.
No, since the discussion, usually there are very few sites where it has got utility. Like breast has got more value as compared to the
Yes.
inguinal nodes, because we all try,
Yes.
it is a bilateral disease. Then invariably I will do superficial lymphadenectomy. If it comes
Block.
positive, invariably it goes indication for a deep. If deep comes positive, ilioinguinal again is an indication for that.
Fine.
Probably one
Fine.
should know for the where it is exactly situated. What is another name? How to classify them? In that setting, probably we may ask about the what is sentinel node. As far as the management is concerned, we don't stress too much on a sentinel node in case of a
Sentinel.
carcinoma
Yes.
penis.
Yes.
Probably it may be
So,
true for the carcinoma breast, may not be that much true for the
not for the
carcinoma
penis.
penis.
Yes.
Penis.
So,
So then another scenario, the presenter I would like to put it here. You have got a penile lesion and you have got a unilateral node. You don't have the opposite node. Still
okay,
you
sir.
want to unilateral node, non-metastatic. Still you want to do a bilateral inguinal, or you stick on to unilateral?
So first I will see the staging of the T staging. So it depends on that.
So you correlate with the primary, right?
Yes,
That
sir.
is what is. That is your answer. You correlate with the primary and grade of
Yes,
the
sir.
lesion also,
Yes,
and
sir.
how the node in the ipsilateral side. So
Yes,
there is
sir.
no ipsilateral in penis. Penis is a midline organ. So there is nothing called ipsilateral in penis. And the involved side, if you have right inguinal node and there are no left node, if the right node is very small and very soft, you just skip it up. Very small primary lesion. You correlate with the primary and grade of the lesion. That is a quite good answer.
Okay.
So why do you want to do an iliac block dissection? In a case of, because in a penile cancer, the regional node is inguinal node. So why do you
Yes,
want
sir.
to do an iliac block dissection?
Sir,
And when do you want to do?
Corporal bodies lymphatics go to iliac lymph nodes, sir. And
See, in
see-
penile cancers, if it is a therapeutic dissection, if you are going to do a plan for a therapeutic, you are not going for a staging dissection. If it is a
yes, sir.
therapeutic dissection, it is always bilateral ilioinguinal block dissection. We just register it. It is always a bilateral. If it is a therapeutic, if it is a N1 node, if it is an N plus node, it is always bilateral ilioinguinal block dissection. Fine. You don't restrict to inguinal or you don't restrict to one side. Fine. And if it is an N0 node, you just take it like this. If it is N0 node, you go for a superficial block, then frozen, then proceed. Then if it is an N plus status, you go for a complete dissection. Ilioinguinal block dissection. That is the thing. That is a standard thing. Fine. If there are parietic nodes, then it is a metastatic disease. And there is no point in going and dissecting all these things. And that is a very unusual situation. In a penile cancer, to have a iliac, inguinal, iliac, and parietic. Very unusual. So parietic going, answering as a parietic dissection is not indicated here. Parietic is a metastatic. This up to this level you have to understand. Okay. So what will you contemplate here? If just say that it is a single penile lesion confined to glands, and what will you do here? Partial or total?
So it will depend on the grade and size of the lesion, and sir, whether it is invading deeper structure or not, sir. And I will like to keep it as a partial amputation because it's beneficial for the patient's self-esteem and
So I'll put it in other
status.
words. When will you contemplate a partial? Penis is not a fixed structure. So penis doesn't have a fixed length. See, femur length is 25 centimeters.
Yes,
Cervix is 25 centimeters. Penis doesn't have fixed length. Varies depending on individual to individual, age to age. So it doesn't matter with the size of the tumor, right? The tumor can be 2 centimeter and the penis can be 10 centimeter. The tumor can be very large and the penis can be very large also. Even then you can go for a partial amputation. So what is the criteria you will fix for a partial amputation? Partial versus total amputation. So in other words,
So
how
if
much
we
margin
can,
you will give for a partial amputation? What is the
sir,
margin
it
you will
depends
give?
on the primary lesion, sir. So it
See,
depends on the
Dr.
primary
Apurva,
lesion, sir. If
Dr.
it's
Apurva,
yes, sir.
try to understand what sir is trying to ask. One is definitely you cannot compromise on the oncological principle. You have to have a negative margin. What is the other advantage, the other thing that you want to achieve by preserving the organ? So you are again saying
So
stage.
the
But
function,
one is the local control, management of lymph nodes, sir has already elaborated very well. As far as the
yes, sir.
local control is concerned, as far as in this stage, you don't have any option of say organ preserving. You have either partial and total. So for partial, sir is asking what
Yes, sir.
you are trying to achieve. What is the principle?
So if it is primary is still T2, then we can go for the partial amputation with a margin of 5 to 10 mm. And in case of T3
Sir,
or
shall I
T4, we
interrupt the
have.
presenter here, sir?
Yes,
Sir,
sir,
shall I
sure.
interrupt the presenter? I think he is not clear, sir. So he is just confused. See,
Yes, please go.
you need a 2 centimeter from margin from the edge of integration. So 10 mm, 5 mm doesn't hold. It holds only for a basal cell carcinoma, that only in a face, not in a penis, right? So penile cancers, it is only 2 centimeter margin from the integrated edge. Fine. And
Okay.
you need additional of 5 to 1 centimeter. Sorry, 5 mm to 1 centimeter for the flap. And you should need 2 centimeter stump at least of the residual penis for a projectile urine. This should be your answer. So
Okay.
at least you need 5 centimeter of normal penis to contemplate on a partial amputation. So 2 centimeter from the for the margin and 1 centimeter for the flap, whatever it is, you spatulate the urethra, you put there's all these cavernous, all these things, and 2 centimeter for residual penile stump, minimum 2 centimeter residual penile stump for a projectile urine, right? So you aim
Okay,
for a partial amputation with 2 centimeter margin, and you should get at least 2 centimeter stump for projectile urine. Without giving a projectile urine and the urine dribbling into the scrotum, in that scenario, you are adding more and more problems. So that is not indicated. If you are not able to achieve this margin, 2 centimeter margin and 2 centimeter penile stump with the flap covering, there is no point in doing a partial amputation. You can very well go for a total, and you can go for a perineal urethroplasty. That should be your answer. Fine.
sir.
And you just forget all these
Okay,
things,
sir.
this T2 grade, all these things. That's all you're beating around the bush. There should be a clear-cut answer. Fine. And forget about 1 centimeter margin.
Okay, sir.
Penis is such an aggressive disease. If you get a local recurrence, it is a hell for the patient. And if you get a nodal disease, it is again a bad disease. Only when the penis is confined to penis, there is no nodal disease, and very early stage, it is a good disease. Okay, fine. Once it has invaded the nearby structures, once it has metastasized lymph node or iliac, the patient survival goes down, very much down. So you should be very aggressive in your local management, and nothing like organ preservation comes first. It is an oncological clearance comes first, right? So 2 centimeter margin is 2 centimeter margin by scale, not by your finger or by imagination. 2 centimeter margin by your scale. Fine.
Okay, sir.
And another thing to add is you have to get negative frozen margin. You have to add a frozen also. You got to get the margins done by frozen, and that should be negative. Right.
Dr. Shahid.
Okay, sir has already told you about the management of the primary site. As far as the lymph node is concerned, the scenario was both turned out to be negative. I am going to give you another scenario. Suppose on one side the lymph node is showing the ulceration over the surrounding skin. Then what will be your stage then with positive on the biopsy?
N3.
N3, sir. It will be N3.
Okay. Is there any difference in management if you are having a locally bulky disease nodal mass versus the one with the early, say, stage 1 palpable lymph node N1?
Sorry, sir. I didn't get the question.
I am asking is in a case where you are getting a bulky nodal metastasis, say, involving the skin or the multiple bilateral large lymph nodes. So, is there any option other than going directly for surgery?
So we can go for neoadjuvant chemotherapy and then go for the ilioinguinal dissection.
Okay, can you tell me any regime that you are aware of regarding the neoadjuvant chemotherapy in those scenarios?
So the neoadjuvant chemotherapy must include cisplatin-based regime. So the cisplatin, ipsophosphamide, and paclitaxel can be given.
What about the conventional 5-fluorouracil and cisplatin combination?
I don't know about that, sir.
So per se, some in guidelines, what they say ki if you want to use it for neoadjuvant, then the paclitaxel, ifosfamide, and cisplatin is the preferred one, and 5-fluorouracil and cisplatin is not preferred to be used as a neoadjuvant chemotherapy. So what will you like to see following this neoadjuvant chemotherapy, and how many cycles you are likely to give to the patient?
So the 3 cycles I will like to give.
Okay. And what will you like to assess in post of
any decrease in the lymph node mass, and if the fixity has decreased or not.
So you'd like to assess for any regress or improvement as well as for any progress of the disease.
Yes, sir.
That is all from my side, sir. Any question from the other faculty, please?
So you will preserve the scrotum or you will remove it in this situation?
So I will preserve.
So if you are going to do a bilateral ileoangular block dissection and a total penectomy, perineal urethrostomy in this situation, fine.
Yes,
so what
sir.
complication you will expect if you preserve the scrotum? See, this case, you are doing a total penectomy, perineal urethrostomy, bilateral ileoangular block dissection, and you say you are not going to remove the testis and scrotum. Fine. So what complication you will face?
Yes, sir.
And in this case, this patient and the sir has asked about neoadjuvant chemo, all these things. And if this patient turns out to be node positive, iliac node positive or inguinal node positive, what will you do? You will add upon some adjuvant treatments. Single node positive, low grade, you won't give radiation. Fine. If it is multiple node positive, high grade, and iliac node positive, you will give add with chemo and radiation. So what complication will you expect?
So if the perineal urethrostomy is done and yes, sir. So then there will be problem during the micturition whenever the patient will be going for.
See, it is simple. It is simple. See, perineal urethrostomy will not come under this RT field and all. See, you are removing all the lymphatics. Scrotum drains, all the scrotal skin structures drain to the inguinal node. So you are removing all these lymphatics, and again you are removing the iliac nodes also, and you are irradiating this ileoangular region also. So naturally they are prone for more of lymphedema. Okay, scrotal lymphedema. You will get a scrotal lymphedema, and this lymphedema will be very distressing to the patient. Okay, it will be just like another thigh.
Okay, sir.
And it will be irritating the thigh skin, irritating the perineal skin, perineal urethrostomy, and there might be scrotal maceration. See, in case if it is an early disease and a very small nodes, and you don't think if he is a young patient and you need to preserve the testis in all these sections, you want some hormonal influences for the testis, all these things, so you can preserve this. If it is a gross node, as your sir is saying, like you're planning for a neoadjuvant chemo or adjuvant chemo radiation, it is better to remove the scrotum also, provided you are planning for a perineal urethrostomy.
Okay,
so you avoid all the other complications. If you retain the scrotum, you will come back again as a huge scrotum. You have to balance with the clinical situation. It is not hard and fast. Whenever you remove this whole penis, you need not always go and remove the whole scrotum. It is not a hard and fast thing. You have to balance with the patient. If he is a young patient, you can preserve the testis. If he is very old, 60 something, you will be always coming through your review OPs. You won't be bothered about the recurrence. You will be bothered more about the scrotal area. Then what is the important complication of ileoangular block dissection? What is the dreaded thing? There are many questions. What is important, common, dreadful? You have to keep in mind wound breakdown. Wound breakdown is the commonest one in an inguinal block dissection. Fine. So then if the wound breaks down, what is the structure which is exposed?
So femoral
femoral will get exposed. So if there will be femoral blowout, and patient might pop off. To avoid that, what you do there? You cover the femoral with
sartorius muscle transport.
That is called sartorius muscle. Very good. Very good. So only up to this you will be asked.
Thank
And
you.
if you are doing very good, you will be asked
Okay.
about sentinel node all this.
Thank you.
Thank you, sir.
We have
Shadin?
one more. We have one more. Ishwar sir, we remember that scalp swelling. Yes, Ajay,
Give me
can
some
you
time. Give me some time. Shadin sir, do you have your comments, sir?
please? Sorry, sir. Sorry, sir.
No problem. No problem.
No, sir. Thank you very much, sir.
Dr. Kanna sir. Sir, you are in mute mode, sir.
Yeah. Can you tell what are the various ways of organ preservation in the CA penis? Various modalities which are there to have the organ preservation.
So we can go for the radiation if the lesion is less than 4 centimeter.
Types of radiation which are given.
So the
What are the
external beam
various
radiotherapy.
types of radiation which you can give in?
Yes, sir. So external beam
Yes,
radiotherapy or brachytherapy.
Any other type of the radiotherapy? How do you get the
So
brachytherapy?
there is a penis is put between the
Which are the radiotherapy agents are used there? Where you would like to put it?
I don't know this, sir.
You can put a mold over that, or you can do the interstitial type of brachytherapy, right? Where you put the needles in that is the interstitial type, or you can put a mold. Okay, apart from the radiotherapy, what are the other organ preservation thing which you can carry out?
It's a very early disease.
So
Is there.
if
What do you
the we can
Very
go
early
for
disease is there, what can you
immunotherapy.
do?
So we can go for immunotherapy or the topical application of 5-fluorouracil.
Right.
And
many times,
the
just circumcision will many times will help if it is not responding.
circumcision, and the laser we can go for laser application also. CO2 or Nd:YAG.
Which laser is usually used for this?
So
Which laser is used for? You can use the Nd:YAG. You can use the CO2 laser, which is a cutting laser, or you can also use the KTP
CO2
laser.
laser has yes, sir. Yes, sir.
Right?
Yes, sir.
What is Mohs surgery? MOH.
Sorry, sir.
Mohs.
Sir, it is Mohs micrographic surgery.
Is that you cut the tissue layers and you do the frozen section every time and see that when that area is now not containing the malignant cells now. Okay.
Okay.
So these are the various types of the. Noted, what is the cause of the death in cancer penis?
So mostly it is due to
How does the patient of cancer penis dies?
So it is due to involvement of femoral artery by the metastatic lymph node, which causes it to blow out, and torrential blood loss.
Right. So femoral blow out is one of the causes. Right. Now, when you're doing the block dissection, how can you prevent the flap necrosis?
Sorry, sir, I didn't get the question.
When you're doing a flap, like
prevent the flap necrosis,
what are the strategies to avoid a flap necrosis?
So we will transposition the sartorius muscle.
No, please take the question in the right sense. See, when you're doing
that is going to cover the femoral vessels, isn't it?
Okay.
Dr. Apurva, the question is very simple.
Okay, if you do too much of the mobilization of the flap, then the vascularity will decrease.
Okay.
Okay. If your
Okay,
flap
sir.
is very thin, then
Vimal sir, I think you can give answer to the question as an exam answer, sir. Sir got disconnected, I think. Kannan sir, you're back.
Yes, sir. So you have to, there is nothing like thin flap or thick flap. That depends on the patient habitus, sir. It's just like breast, fine. It is within the boundaries of the dissection, you have to raise the flaps. So inguinal block dissection, the boundary is, Apurva, do you know what it is? What are the boundaries?
so you have to
So
You have to
the
limit the flap raising just up to the boundaries. You don't go much beyond the boundaries. So the capillate boundary is 5 centimeter above the inguinal ligament, right?
yes, sir.
And medially it is medial border of adductor longus, laterally it is lateral border of medial border of sartorius, and caudal it is the apex of femoral triangle. So you don't dissect beyond that. First thing. Then limit usage of cautery. Next thing. Of course, you naturally have to use the cautery dissection, but if the patient is very fragile, very old age, and skin is very thin and diabetic or all these things, you can even raise with a knife, with a 15 blade also. That is also fairly good. And I have done few cases and seen some good results with that knife raising also. Then the flap should be just beneath the scarpus fascia, because beneath just deep the scarpus fascia, you will get the nodes.
Notes.
Okay. If you just keep the flap raising anterior to the scarpus fascia, you will be going between the subcutaneous fat and scarpus. So that is the plane. That is a plane of flap raising, and that might vary in thickness depending on the patient habitus. There is no hard and fast whether it is 5 mm or 7 mm, like that thing like that. This is the thing basically we follow.
Kannan sir, I need some clarification.
Yes, sir. Yes, sir.
With the modality of minimal invasive, all these complications are taken care of.
Pardon, sir. Pardon. Minimal invasive.
With the use of minimal invasive technique.
Minimal invasive. Okay.
All these complications of flap necrosis, wound breakdown, are they really
naturally,
taken care of?
it can
Could
be
you able to
taken
get
care,
the
sir.
yes?
So it can be taken care, but the prime aim in any oncology is a clearance, fine. Rather than a complication. Rather than the complications. Your prime focus in any cancer patient should be the oncological outcome. Next one is to reduce the morbidity, and third one is functional outcome. Only last comes the cosmetic outcome. If you satisfy all these first three, oncological outcome, functional, morbidity, and all these three are satisfied, you can go for a cosmetic, just like where you see in a breast. You don't compromise all the above three, then you can look into the cosmetic outcome. So that is where we stand. But to boost up all these things, the cosmetic outcome comes first in the scenario these days.
So in the initial stage, probably it was true for even for colonic carcinoma and gastric carcinoma, pancreatic carcinoma.
Yes.
With the advent of so much of surgeries, there has been number of yield of possibility is almost equal to the open surgery. Probably in due course, this also after some time, probably it may be standard of care.
Definitely, this will replace. Yeah, definitely. But since there are not multicentric trials and so much are not going on, this has not been so much proven. So maybe in colorectal, this will replace in the future. Definitely.
Shahadan sir, would like to add any points?
Okay, so Dr. Apurva,
yes, sir.
Other than the complication related to wound, what else are the specific complications that can occur? And is there any post-operative measure that you can take to take care of that? One is the said flap necrosis and wound-related complication. Anything else in relation to the lymphatic dissection that you can see post-operatively? For many days, you may see the patient.
Sorry, sir. I don't know.
So, give the answer, sir, maybe.
The answer is in the question itself.
I know, but as a student, they never pick up the clue. The examiner thinks he gives the best of the clue from the student perspective. It is perfect. Is there anything like a long-standing collection or a sub-flap collection in a better way to make it simple for you, Apurva?
So there might be sedoma or the seroma in the beneath these flaps, sir.
So what should be your management approach when you develop seroma?
So we can go for the needle aspiration and
Apurva, first I would like you to answer in this order. Avoidance principles of seroma, number 1. Number 2, there is seroma. Is there a seroma which can be just left under observation? And what are the clear indications for aspiration? And when do you surgically intervene? These are the 4 types. Whenever you are asked for a question, you have a system to answer. Then the examiner feels you are a confident answer student, right? Please go ahead in that way. What are the steps of avoidance?
sir, if the seroma is localized or not increasing in size or very small in size, so we can
Sir
avoid
is first
intervening
asking
or do anything.
Dr. Apurva, listen to the question. Sir is asking, how can you prevent this seroma or lymphoria post-operative? Intraoperative, what are the things that you can do to prevent the chances of seroma that you are saying here, lymphatic leaks post-operative?
Pressure, we can do pressure dressing that will decrease the chances of developing a seroma. We can put a drain intraoperatively.
Okay, intraoperatively, anything else? Earlier, there is a suggestion that step that you can take. Like, sir, one thing the sir said, the limited use of cautery and ligation of the perilymphatic the tissues that you should use to ligate them. These things, I don't know how true it is. I have not is my experience. Sir will better tell you. But these are the things that they say, and pressure dressing, drainage, all those things. What else? Like sir was asking, anything else you want to add?
Vimal sir, I think intraoperatively, what are the important points you can give in a nutshell?
Regarding this seroma, sir, or just about the procedure?
In seroma, sir. Let us finish this. It's a short note question for them. Complications after a Bach dissection. So I would say, let us. You have discussed about the flap part of it. Now we'll discuss quickly about the collection part of it, and then move on to that.
So collection part of it, adequate drainage. You need to place a suction drain, and usually the drain will be there nearly for about 10 days to 15 days, and early mobilization, stockings in the lower limb. And despite this, there might be some collection, pockets of collection might happen, even if the drain is functioning also. Despite this, there might be some collections that has to be aspirated naturally. And usually we'll do a delayed suture removal, and this wound might get breakdown if the sutures are wound might get opened up if the sutures are removed in the routine time interval. This is what the routine things we do, and of course limit the usage of cautery and absolute hemostasis. All these things that applies for any surgical situation.
Thank you. Thank you.
And in the post-operative period, avoid any needle stick injuries in the lower limb. Just like he might be a barefoot walker, or he might be a farmer, or going in the so that might provoke lymphedema and all these things. That is most common things. These we might be doing good block dissection. They won't have any complications in the near immediate post-op period. They might come up after 1 or 2 months. They might come up with lymphedema again. Probably there might be walking with barefoot and might get thorn pricks or something. That will provoke lymphedema. That is a common thing we see in the post-op periods. And they may get lymph injuries.
Seroma.
For a seroma, you can put a pigtail if it is prolonged. You can put a pigtail catheter, but usually that doesn't stay there, sir. Because of gravity, this pigtail will fall down. That is a problem we usually face. Putting a pigtail under guidance of ultrasound is quite a good technique. If it is a prolonged seroma, occurring for more than for a long time, for months together. And usually we don't give some sclerosants, all these things. It will settle. It will take time to settle down. Naturally, it will take alternate lymphatic pathways has to develop, and this muscular strength has to develop, and limb circulation has to develop. Only then this seroma will reduce by its natural course, and not with any of your already all these things, small maneuvers like sclerosant, all these things. And you might be inviting some other problems also, introducing infection, something like that. If it is very distressing, you can go for a pigtail, and that is all not a standard one. It is all individualized. If it is very distressing, if he is an office goer and is not able to go for office or something, you can very well go for a pigtailing session.
Thank you, sir. Like, yeah, I think it is more of a departmental protocols than definitively published studies.
Yes, sir. Yes,
in
sir.
our
Yes,
department, we follow seroma. If they turn painful, if they turn symptomatic, or
yes, sir.
the
You go
patient
for
has
ultras.
features of infections, if the patient has cosmetically very, say, limiting flexion, those are all very rare, but still patient-driven factors are the principal thing. And of course, infections are the definitive indications we expect people to intervene. As sir said, more of a, see, when you try to open drain it, it's going to take a long time. Sometimes dressing a seroma is a very messy affair because it's a sad thing for these patients. Sometimes it can leak 200, 300 ml also. So it becomes very messy to patient becomes sort of a very depressed, like it's not, see, your bowel or intracutaneous fistula also can be bagged up, but this seroma bagging is quite difficult, and especially in this flexion region, it's a quite challenging one. That's where, as Dr. Vimal sir said, a controlled drainage option by using a pigtail, or sometimes we in fact reintroduce vacuum drains that makes life much easier. So it becomes controlled, and vacuum drains are relatively better off than pigtail because it has multiple openings. Yes. That is what we follow. I think these questions are specifically driven for you for the virtual round session. So various universities have different pattern. At least the national board have virtual round.
And if it is an open wound with a seroma and a non-healing wound because of serous collection, definitely a vac will be of so much of help rather than jumping into a secondary procedure like SSG or something like that. A vac will definitely reduce the wound, and it will be very easy also. It can be managed in the home itself, and patient can feel much more better rather than coming back to the hospital. And there are people around, they can go and get the dressing done at the home itself. It is VAC and all these things.
VAC is very resident friendly also, sir. We are seeing most of our residents, as and when they get the opportunity, they will try to put the VAC because it gives them more time to have other things.
And
number of dissertation for increased. With VAC therapy, number of dissertation topics are increased.
Yes, sir. Sometimes we may be stuck in wound management. So in that situations, VAC will be of so much of help to us.
Sir, I also would like to tell that we have something else to coming up. So Apurva, do you have any questions before we have a very brief presentation by one of the PGs who presented earlier?
No, sir.
Thank you, Dr. Apurva. Thank you, Dr. Sudipta Saha and Sadhan sir for sharing your expertise today. Vimal sir, thank you, sir. I would request all of you to stay back for 2 minutes. We had a presentation a couple of weeks before from Tirunelveli Medical College. Vignesh, can you quickly share your presentation? Kanna sir, you will also be happy to hear.
So that scalp swelling, sir. The cell is not there.
Please share your screen. Yeah.
Yes.
You look nice, man. Show the PowerPoint.
Photo allowed. Ignace.
This is good, Srinivasan sir.
No, sir, this is not his photo. He is mask free.
Yes, sir.
Ignace, but he's keeping it so much time. Hey, matrimonial column, Lada. Ignace, sir. Would I'll share.
PowerPoint, Srinivasan.
Ignace, leave it, I'll share. You have it.
Hello, sir.
You share your screen, ba?
Yes, sir. Sir, yes.
No, you stop.
You cannot start screen.
You stop.
Sir, Srinivasan sir, please share the screen. Vignesh, you can use the sir's PowerPoint.
Yes, sir.
Yeah, just tell what.
Burning. Sir?
1 minute, 1 minute. We can see the photo first, then we can So this was the case, Vimal Kannan, presented
Yes,
by
sir.
from Tirunelveli Medical College,
Yes,
with
sir.
nodes around.
Yes,
It
sir.
was
The
operated.
occipital nodes are there. Level 5 nodes were there. Yeah.
So operated. We were Ajay Khanna sir, and we all wanted to know the pathological report. He had got it yesterday.
Okay.
It was supposed to be squeezed in. Yes, President Ba.
Good evening, sir. I am Dr. Vignesh, final year postgraduate from Tirunelveli Medical College. I am here to present the histopathology report of a patient named Mr. Arunachalam. Is a case of squamous cell carcinoma left occipitoparietal region, and a procedure which was done was wide localization of the tumor with the left radical neck node dissection. The nature of the specimen which was received, we took 3 specimens. Lesion A, it was the squamous cell carcinoma of the scalp. B, and the left cervical lymph node levels from level 1 to level 5. And the C specimen is the involved bony segment, that is the outer table of the left perioccipital region. The description, lesion A, it had a specimen of wide localization measuring 10 into 9 into 5 centimeters. And the external surface, it showed ulceroproliferative gray, measuring 9 into 8 into 3.8 centimeters. Mass lies at a distance of 2.5 centimeter from the superior resectal margin, 2.4 centimeter from the left lateral resectal margin, 2 centimeter from the right lateral resectal margin, and 3.5 centimeter from the inferior resectal margin. Deep resectal margin appears to be involved. B, the specimen of left radical neck dissection measuring 10 cross 6 cross 4 centimeter also received separately from the soft tissue fragment measuring 5 into 4 into 2 centimeter. Cut surface also includes the salivary gland measuring 2.5 into 1.5 into 1 centimeter. The cut surface salivary gland, no remarkable changes. Internal jugular vein was seen, which was present measuring 7 centimeter length. Level 1 nodes, 9 nodes were sent, largest measuring 0.8 into 7. And then specimen C, which was the outer table of the left perioccipital region. Microscopic description, the lesion A, studied from the ulceroproliferative growth, showed malignant tumor cells composed of malignant squamous cells arranged in nest, sheets and cords. Individual cells having moderate eosinophilic cytoplasm, some with clear cell changes, round to oval vesicular nuclei with a prominent nucleoli. The deep margin is involved with the tumor. Section studied from the all other resected margins were free of tumor, and the lymphovascular invasion is seen, but no perineural invasion. Section B, the section studied from salivary gland shows normal histological features. Section studied from level 1 shows 1 out of 9 nodes with metastatic carcinoma deposits. Section studied from level 2 also shows 1 out of 9 nodes from metastatic carcinoma deposits. And section studied from level 3 shows 7 nodes with reactive follicular hyperplasia and free of tumor. Section studied from level 4 shows 1 out of 3 nodes with metastatic carcinoma deposits. Section from level 5 shows 4 nodes with the follicular hyperplasia and are free of tumor. Section C, section studied from bony fragments shows malignant tumor composed of malignant squamous cells arranged in nest, sheets and cords. Individual cells having moderate eosinophilic cytoplasm, some with clear cell changes, round to oval vesicular nuclei with prominent nucleoli. Impression, it is a clear cell variant of squamous cell carcinoma scalp. Salivary gland is normal histology feature and free of tumor. Level 1, level 2, both 1 out of 9 nodes with the metastatic carcinoma deposits. Level 3, 7 nodes with the reactive follicular hyperplasia and free of tumor. And level 4, 1 out of 3 nodes with metastatic carcinoma deposits. Level 5, 4 nodes reactive follicular hyperplasia. See, the involved bone segment is involved for malignancy. This is the preoperative images, sir. Intraoperative wide localization is done. Outer table was removed. The patient came for follow-up after 2 weeks. This is the current image.
So, Vignesh,
wound covering is planned after 2 weeks, sir.
Vignesh, I just want to interrupt here. So, how did you remove this outer table?
Yes, sir.
How did you remove this outer table?
Vimal, they are
Yes, sir.
they are discussed the
Outer
tumor and they are taken the case for surgery. They have been
Okay,
asked to
sir.
do, the plastic surgeon said, we will do the cover later on.
Sir,
So,
actually,
We were eager
what
on
we
to know the report of that one and the
fine,
notes.
fine. What they could have done is, so they would have fairly they would have got some good idea of the deep invasion of the tumor with scans itself. So with CT itself, you would have known that there should be some bony invasion, right? So obviously we cannot get much more margin than this. What they have done is a fairly good resection, removing the outer table, all these things, and definitely we could have given a coverage for the scan. And you can add with radiation, because you cannot do anything apart from this. Surgically, you cannot do anything apart from this. What you have done is fairly good resection. You have resected the primary, resected the given good margin, deep margin, only this much can be given, and you have done a good nodal dissection. And naturally, it is a microscopic margin positive, right? Deep margin is positive. So the only adjuvant which is possible here is radiation. And of course, if it is not positive, you can give it cisplatin-based chemotherapy, all these things. And if you want to add up a radiation, it should be given at least within 4 to 6 weeks time. Why you didn't cover this wound with a flap? That's my question here. That's my concern here.
So the case,
you could have fairly
was,
done a flap here. You could have fairly done
yes,
a
sir.
rotation flap
But,
from the scalp, or you could have done a LD flap also. It is accessible.
but,
For an LD flap
like,
also, it is accessible, and a rotation scalp flap is also accessible. Because you have removed the outer table, SSG is not possible, but you could have done a flap. Did you present the case in a forum with a tumor board involving oncologists there?
Yes, sir.
Surgical oncologists were there?
Yes, sir. Yes, sir. Tumor board, we discussed the case, sir.
Okay. Surgical
Yes, sir.
oncologists
It
were
was
there?
planned. Yes, sir.
Dr. Sundaram, Anita were all there.
Yes, sir. Yes, sir. Yes, sir. Sundaram, sir.
They accepted for a secondary flap coverage.
Yes, sir. It was planned for initial flap cover, but we consulted the plastic surgeon opinion, and they told that flap cover to be done at a later stage.
Hey, which one is more important, man? Cosmetic or oncological outcome? You have done such a beautiful resection. Yeah, you have done such a beautiful resection, such a good radical neck dissection. You have removed the outer table, and patient is having a very good life after surgery. This is a very good outcome for the patient. And if you say if you are doing a flap after 4 weeks and another wound healing for another 4 weeks, if you give radiation after 3 months, naturally you are losing the window period, right? It's okay, but it should be primarily reconstructed. The concepts of secondary reconstruction, delayed reconstruction are all gone. Even if you are going for a margin positive resection, you have to reconstruct primarily itself. Right?
Okay, sir.
It is very good resection, but you should have reconstructed primarily. That is fine. And by this time, by 4 weeks, you should have started radiation. See what you are aiming. You are aiming for a good cosmosis without life. Life is more important than cosmosis. If he recurs, it will naturally invade the inner table also. Then the dura also.
Okay, sir.
Fine.
Okay.
The reason I will tell you, Vimal, listen.
Okay.
The reason I tell you, Vimal, he cannot tell it because he's a postgraduate.
It is a
I told
forum,
Kanagavel also. He told me also. I will tell you separately.
Sir, I think
then
they have some challenges.
Vignesh, okay, Vignesh, you have to go for a CT chest also. Such a big node and node positive disease. Before you are planning for a curative resection, CT chest, you might get some mediastinal node or lung mass. Though rare, you might get some.
Okay.
So then, then out of interest, have you read about posterolateral neck dissection?
Sir, one query about this case, sir. Excuse me.
Yes, Shadhan,
it is classically described for an occipital squamous cell carcinoma.
Okay.
Posterolateral dissection. Because you have done a level 1 dissection also, because it is a quite big node, quite big level 5 node, and level 1 node is also involved. What you have done is correct, but to add to this discussion, for an occipital scalp squamous cell carcinoma, posterolateral dissection for N0 neck. That is the only indication for a posterolateral neck dissection.
Shadhan sir opened up.
Okay, so just one suggestion. Actually, looking at the case preoperatively, it seemed to be quite a big size tumor. Definitely, it is a well managed case. I think it must have been very difficult, but your team did a very good job. As sir was saying, I think there are a few things that I noticed, and I would like just a clarification from the sir. Since the size of the tumor, even for squamous cell carcinoma, this is around 10 centimeter or so, with deep invasion and presence of lymph node itself is an indication that patient required adjuvant radiotherapy. In those settings, as a surgeon, should not we insist our plastic surgeon to give say coverage immediately so that we can speed up with the adjuvant part. That is the suggestion I do, and a point that I noticed.
Thank you, sir. I think they had some other logistic challenges. That was the reason it was not done. But for all technical reasons, I think we agree with both Dr. Vimal sir's view and Dr. Shadhan's view that it has to be a in parallel resection and flap cover should be the ideal therapy which should have been given for this patient. Anyway, we wanted the biopsy report to be shared because at the time of presentation, we didn't have the postoperative histology. That's the reason we requested Vignesh to come in. Thank you, Vignesh. Thank you for
Thank you, sir. Thank you, sir.
Anyway, Vignesh, it is a very good resection. Nice.
Thank you, sir.
Very good resection. It was wondering to remove the outer table. Right. Very nice case. You can even present some papers. Few
send it
like
for a case report
single
in the
cases.
journal.
Yeah, yeah.
Okay, sir.
Very nice.
He generally can publish, sir.
Yes, sir. Yes,
This
definitely.
will get published in regular journals also, sir.
Yes, sir.
Not a very common case to see. Shadhan sir, you want to add something before we call it a close?
No, sir, just I would like to share an experience of mine also, because you people are here discussing a case of squamous cell carcinoma. I had operated a case of squamous cell carcinoma, and that was a margarine ulcer. We had a lady who was 45 years of age, and she had a post-burn scar and contracture of the right knee and right elbow, and there was deformity of the wrist also. There she was almost, it was there was no movement at this joint, and she was also having a large tumor almost occupying 2/3 of the circumference, and it was 15 into 6 centimeter with MRI and CT finding all, and it was near the right elbow. And it look, and MRI also was suggestive of some local infiltration around the muscles and some deposit. So it was very hard for us to convince her, because, and there was auxiliary lymph node also, and it really took a lot of time for her to convince and her to go for amputation, and she was insisting to preserve that limb, because with the length itself she was taking care of 4 or 5 kids. She was able to roll the chapati. So I think not only the ignorance part, but it is the social responsibility of the people of the India, particularly with the poor socioeconomic status. That is one, also one of the reason why our patients are coming late to us, and say we are feeling with, we are having a difficulty in offering the more conservative surgery, like in most of the developed countries that they are offering. And now most of the things that we see is more and more conservative and more of the less invasive approach. But often what we see, it is not the ignorance, but also the social and the family responsibility on the part of the patient that make them to present in such a late stage.
Thank you, sir. Thank you. Vimal sir, would you like to add your views?
Sir, nothing, sir.
Thank
Fine,
you.
sir. Thank you.
I thank Dr. Shadhan sir,
Thank
Dr.
you, sir.
Srinivasan sir, Dr. Ishwar sir, Dr. Vimal sir,
Thank you, sir.
and
Thank you.
Apur Saxena
Thank
and
you, sir.
Guru Shankari, and the faculty who joined in between. Professor Ajay Khanna sir had a poor connectivity, and Naveen Sharma sir will be joining next week. He has a minister call and he has to go for the COVID meeting. That's what he updated me. And regarding the next week, Dr. Rajgopal Chennai sir has told that there will be ASICON. I am just working for the final program. I think right now I also received a mail from the ASICON I think we may need to reschedule a little bit. Let me take with the consensus of the other faculty, senior faculty members regarding the next Friday class. Either there will be a delay in start of the class, or we don't want to clash with National Lexicon. It is a principal event of our country. So let me decide about that in consultation with the senior faculty and inform you about the class. The next week class is a case of, I think from Dr. Ishwar sir's unit, GI malignancy with hepatic metastasis. And we have another interesting case from Manipal also. We have cases lined up. So I will inform you in the invitation regarding the final case after I confirm the timing with the respective faculty. Thank you so much.
Thank you, sir.
Apologize for the delay in starting the session by a few minutes. I thank Dr. Srinivasan sir for bridging up my.
Thank you. Thanks, sir. It's a duty.
Sir, thank you. Good night, faculty. Good night.
Good night.
Thank you, Kanagavel, sir.
Thank you, sir.
Thank you,
Thank
sir.
you, sir.
Good
Thank
night.
you, sir.
And
Thank you, sir.
my
Yes, sir.
apology to all if